Hello, everyone. Good morning. Good morning. All right, welcome back. Welcome back, everyone, to our day two of our third international conference on nursing science and healthcare. This 23rd of October, year 2021. And we will now proceed with our parallel session two, which will be about the nursing and healthcare. Let me check. I am looking for our session chair from our audience. Hold on. Just want to make sure that we are all here. Good morning, everyone. I would like to thank again our organizers, Society of Nursing Practices or SFNP, and BioLeagues Worldwide, together with or in association with ITM University. All right. Let us welcome our session chair, Navpreet Kaur, Associate Professor, Department of Nursing, Chitkara School of Health Sciences, Chitkara University, Punjab, India. Welcome back, everyone. I really do apologize. Again, welcome all to the second day of our third international conference on nursing science and healthcare, organized by Society of Nursing Practices and BioLeagues Worldwide. I'm sure you had a great day yesterday with us and hope to see the same enthusiasm from all our presenters and attendees today. I would like to welcome all our honorable dignitaries, and eminent keynote speakers. Dr. Ponchita R., Professor and Vice Principal, MGM, New Bombay College of Nursing, India. Dr. Rajni Sharma, Assistant Nursing Superintendent, Homi Baba Cancer Hospital, and Mahamana Pandit Madan Mohan Malaviya Cancer Center at Varanasi, Government of India, Department of Atomic Energy, India. Dr. Manisha Nand Kumar Pawar, Professor Kum, Vice Principal, Tata Memorial Hospital, College of Nursing, India. Dr. Shamila J., Principal, College of Nursing, School of Health Sciences, Davanada Sagar University, India. Dr. Salwa El Shaid, Professor, Fayum University, Egypt. I welcome all once again to this third International Conference on Nursing Science and Healthcare 2021. I hope you will have a great day with us today. And now, let us welcome our first speaker, currently working as a professor, cum vice principal at MGM, New Bombay College of Nursing, MGM Institute of Health Sciences, Navi Mumbai, Maharashtra. She has completed her master's in nursing and sociology and PhD in nursing. She is currently pursuing FAMER, FAIMER Fellowship 2019 and 2021 batch. She has more than 18 years of experience and has 18 publications to her credit. She is also the editorial board member of the American Journal of Nursing Sciences, Matthews Journal of Nursing and Healthcare, member of IQAC Committee, Research Cell, Best Scientific Paper Award Committee, Publication Committee, and Board of Studies Nursing, MGM-IHS, and approved PhD guide. Let us welcome Dr. R. Panchintra. Good day, doctor.
Yeah, good morning, and thank you for your elaborate introduction, and all the best to all the panel members who are going to do, and congratulations for a very successful completion of the first day of the program. And it's going to be a tiring day today too, because right from 9 o'clock till 5 o'clock, I have seen the schedule. So everybody, I hope everybody will be enjoying it. Let me start the session, and the topic given to me is ethics in translational research. Is my screen visible?
Yes, it's visible.
Oh, somebody can mute it.
Yep.
People are,
I'm on it.
Yeah. So ethics in translational research. So hopefully the audience are a multi-group like UG, PG faculties and the PhD scholars and everybody. So I'll be going it from a little not too high level and not too lower level so that everybody can utilize my session, right? So first of all, the presentation outliners, first I'll just give an introduction, just the basic of what is research and the types of research and what is translational research and translational process, and the basics of ethics and what is moral and what are the general ethical principles and the good clinical practices, and then with the principles to be applied in the translational process of research. So research, as we all know, research is defined as to search again, research, to search again or to examine carefully what has to be done. It is a diligent inquiry, a systematic inquiry or study that validates and refines the existing knowledge. So I'm not going to go into details of the research and even the translational research. I'm just going to touch up so that I hope the next panel member or whoever it is, they'll be elaborately discussing about it. So there are two types of research, basic and the applied research. So basic means otherwise termed as the fundamental research, which is conducted in order to understand the relationship among the phenomena, what is happening in a normal existence. Maybe it is inside the body, it is related to the physiology, or it is related to something psychology, like what does a human being, when a male or a female, when they are depressed, or it's related to the characteristics of a gene or something like that, or what happens to the blood chemistry when something abnormal physiological happens. So it's Basic is in order to understand the relationship. Mostly it is an exploratory. It is not aimed towards the solution of problems or the facilitation of decision making. So first we have to understand what is basic research. That is the fundamental research to understand what is already existing. Then comes the next comes the applied research. It is a research that is designed to produce findings that can be used to modify or remediate a given situation. Based on the findings of the basic or the fundamental research, we develop on to devise something or to create something to give a solution to a problem. This term refers to those studies that have their purpose and identified practical use or an application. Usually the applied research is built based on the fundamental research or the basic research. So the basic research, as I said, is just understanding the phenomena or understanding the biology to know how does it work. Maybe it may be a normal blood chemistry, it may be a normal psychological process, or it may be a gene characteristics, biomedical, whatever it is. And based on the basic research, as I told you in the previous slide, the applied research, there comes based on this findings, some treatments or the tests or some devices are being developed, and the translational research occurs that where they test whether it can be applied to the people. What are the findings in the basic research? Based on that, they devise something and they are trying to find out whether is it possible, whether it can be applied to people or not. When it is proven in a small group that it can be applied to people and something can be done and there is some effect, then we do the clinical research in a phase wise, that is building and conducting the clinical trials to understand what are the effects of the treatments or the tests which is being done. How well does it work? Does it has any potential side effects? How is the outcome, to learn that. So usually the the research process starts from the basic research, then it goes into a translational, and then it comes into the clinical research, which is so that continuum is the exploratory research till to the targeted development. So now coming to the definition of translational research, it's an expansive and an evidence-based scientific research that transforms the scientific findings arriving from the portals of, as I said you, the basic laboratory researchers or the basic exploratory researches, which is done either in the clinical settings or in the community endeavors, into which leads to the clinical tools or the valuable applications for any solution to any problem. So the continuum is bench to bedside. The usual term which is related to the transitional research is bench to bedside. Bench in the sense which is done inside the laboratory, inside 4 rooms, like what it is, with this very small sample, to the bedside. Bedside in the sense to the real practical situations. So translational research means bringing the bench to the bedside, that is, and then it leads to reorganizing and coordinating the system of care. When it comes to the bedside, when it is done and like an evidence-based practice, when a small level it is being tried out, then they try to reorganize and coordinate the system of care with the newly found out solution. Then once that is done, then the behaviors, change in behaviors in the community of healthcare providers as well as recipients, we try to bring out transitions in the behaviors of the community healthcare providers and the recipients. When the outcome and the output is satisfactory at this level, then it is being recommended for driving the health policies at a society level. So the research translates in such a process, like from bench in the sense from the basic laboratory or at the very minimal exploratory stage, it's being put up in the practical, that is at the bedside. Then when it is put at the bedside or the clinical level, then we try to reorganize the system of care, what all the things, where all it can be applicable and what the things are there. When we get success over it, then we try to bring change in behaviors in the healthcare providers as well as the recipients according to the solution what we have found. And when the outcome is successful, it leads to driving healthcare related or the societal policies. This is a translational process. Usually there are different studies have quoted different types of phases. Some stop with the 2 types, only T1 and T2, and some research review literature, they have told 5 stages of transitional process. As I said, it can be divided into 3 levels. That's like, one is the knowledge transfer, how from bench to bedside to this level it brings. And the next one is the phases, and next one is the gaps. So as I told earlier, T0 level is the bench to bedside level, and between the T0 and the T2 level, there is a gap between the fundamental research and the developing a medical product. That gap is being that gap is being fulfilled at the T1 level. That is what with the exploratory, what we have done at the basic research level, we tried to create the knowledge and to find out some new tools or new solutions. As I told in the first two slides, some concept is being made, and at a small level trials are being made. Then between the T1 and the T2 level, the gap is between developing a new medical product and making it clinically ready. So something is being created here at the T1 level, and we have to test the knowledge what we have created at the T2 level. Then from T2, between T2 and T3, there is a gap for whether it is put, now it is being proved that it is can be used at the clinical level. Now, whether it can be utilized at the routine level application in the clinical practice, or whether it can be commonly used for a general population, because now at T2 level, we would have selected only few samples and very small level of things. Now we have to test it whether it is applicable in general to anybody and everybody. So interpreting the knowledge, how far this, what we have found out, the new tool or the new solution is applicable in a general public. So that gap is being filled up between the 3T level, between phase 3 and the phase 4 knowledge implementation. So now we have tested the whatever we have found out at the larger level. So the gap between the routine application and its population-based effects. For example, if you have done it with the only males, then we have to test it with the females, then we have to test it with the rural population and urban population, then we have to test it with all age groups. That level of knowledge gap is being filled up with the T4 level, that is public health prevention, behavior and lifestyle changes. What changes if we modify the knowledge or the tool or the treatment or the method, what we have found out will be applicable. Then between the T4 and the T5 level, there is a gap between population-based effects and the policies derived from it. As we know that the UG projects and the PG projects are done at a very smaller level, and we say that it cannot be generalized. The studies which can be generalized for a general public, it has to be, the samples should be widespread. We say the sample should be large to generalize. In such cases of translational research, it is not only large samples, it should be widespread samples. Like we cannot say if we have done in one single state like Haryana or Madhya Pradesh, it cannot be generalized. If we have to implement as a social level policy or a health policy, it has to be a multinational study, like some samples from each and every state with different types of population. If the solution or the findings, what we have found is being proven at T4 level and the T5 level, then only it can come as a national health policies. So these are the phases and how a basic research or the fundamental research is being translated stage by stage, step by step, phase wise into a societal or a health policy level. And so everybody can utilize, and it is being useful. So this is the translational process. I hope everybody have understood about the translational process. Basically, it is a research process, translational research process, how the research is being transferred from the basic laboratory or the small level to the health policy level, and so that, and it becomes a knowledge, right? Isn't it? What we study in our books, what is all those things like the treatment for myocardial infarction, the symptoms of myocardial infarction. How did they find out the symptoms? These are the symptoms of myocardial infarction. It is basically the findings of a research somebody has done. They have accumulated all the patients who have come with chest pain. They have assessed the patients with the ECG, what are the symptoms over there, and they have analyzed, and they have found out these are the common symptoms which has come up for all the patients, and they have tried with all general, like adult, male, female, country-wise, state-wise, they have found out, and then they have found out with the symptoms of myocardial infarction, and now it is being widely proven, and that has become a knowledge. So without even second question, it is printed in our book, and we all study these are the symptoms of myocardial infarction. Those symptoms are all the outputs of the research which somebody has done it as a basic small research, and they have transformed it, and it has become a scientific knowledge. So if you understand this concept of what is translational research process, then it's going to be easier for everyone. I have tried to quote a small example of translational research, that is devising an assistive device which helps the blind people to see with aid for audio and haptic inputs. So based on the previous levels, T0, identifying the way sensory inputs overlay at the brain level. This is done as a prospective observational studies. It's just an exploratory study, a basic researcher who is just finding out the sensory inputs. What are the sensory inputs? How the brain is reacting to it. So that becomes the basic data to devise any aid which can help the blind people. So then basic identifying the sensory input levels. So what are the inputs the people have? So based on that, the T1 phase comes. In the T1 phase, based on the findings of T0 phase, they develop audio and haptic sensors, and they develop the softwares for the visual inputs or the aids. So it requires an IT development also. So both the IT people as well as the healthcare people join together and they develop the device at the T1 phase. Now, based on the applied and the basic research, a device has been developed. So this has to be tested. As I said in the previous phase, this has to be tested. So studying the usefulness of the device in a small group of people in a closed environment and with few research subjects, the device is being tested, whether it is right, whether it is of some use, whether it gives a desired effect on those. That comes into the T2 phase. So then comes at a small phase, the effect has been successful. So now we have to put it into a little more broader group, and we have to disseminate it to try out with little more. We have to give it to the patients as well as the clinicians to use it and authenticate it. There comes the little more higher level of trial 3 phase and all those. So disseminate the results, what has been found in the T2 phase to the patients and the clinicians, and it has to be certified, certification of the device, and increase it and disseminate it that such device is available. And we have proven that this has been effective and this has given more effective output. So why don't you try it out? So next comes the T4 phase. When the T3 results has been successful and the output is excellent, then the changing the public health behaviors beyond the effects of treatment, we have to give awareness, that is shift from the intervention to prevention by using health campaigns, recommendations about lifestyle changes and how to do it. So that comes into the 3-4 stage, and then this device can be implemented as in the hospitals or as a social or a healthcare policy by, and it should be made available to all kinds of people without discrimination. So that comes the 3-5 phase. So this is one example how a basic exploratory research leads to a development of a new intervention or a device or something, and how it is tested phase wise and how it comes into the society. Like for example, even the glucometer, somebody would have thought what can be done, and somebody would have devised the glucometer, and it is being done at a small phase. Then it is being done with the blood sample as well as with the glucometer pin finger prick. So when it being tested now, the every hospital and everywhere it's being the finger prick blood glucose level is being accepted. So that is the way the translational research process comes in. So basically at every stage, the ethical principles has to be now. Let us come to the definition of ethics and morals. What is ethics? Ethics refers to a written code of conduct which is defines right or a wrong behavior, and it should come from within. Moral means it refers to unwritten set of rules that provide a frame of reference that we use to help our decision making and to regulate our behavior. When we come to research ethics, these are the principles that we use to make decisions about what is an acceptable practice in relation to the research process or the research steps. These are the common ethical principles. First, when we are planning for a research title or a topic, we have to understand whether there is an essentiality of that topic, whether it is needed, whether something is already existing. I'm going have to see what is the essentiality of process. Everybody asks what is the outcome of the research? What is the expected outcome? So the second one is voluntariness, informed consent and community agreement should be there. There must be non-exploitation of the participants. There must be privacy and confidentiality being maintained. There must be precaution while implementing the interventions or the device, and risk minimization. Competence should be maintained. That means the risk will be there. Like a public interest in the sense like there must be a need for the research. Are you able to hear me? Is my voice audible? Hello?
Yes, you are. You are audible. Please proceed.
Yeah. So there must be responsibility on behalf of the as well as the co-investigator complies to the research protocol what is being approved by the
Did my screen froze or do we lost doctor? Doctor, can anyone hear me?
Yes,
Hello?
it is audible.
Oh, I think it's a I think it's an internet problem. Oh, she's back. Doctor, you're on mute.
Fine.
There you go.
Yeah,
Go ahead, share your screen again, please.
sure. That's what I was finding something. That's what I was asking you again and again. Yeah. Fine.
Yeah, proceed, please.
So ethics is not definable because it is not conscious. It involves not only our thinking, it should involve the feelings also, so that we understand the participants, what all the things
I believe it's her internet connection. All right. We'll go ahead and give her some time and let's go ahead and proceed. Let us welcome our next speaker, currently working as an assistant nursing superintendent at assistant professor at Homi Baba Cancer Hospital, Mahamana
Hello,
Pandit.
can you hear me?
Yep.
It's very sorry. Yeah, my internet is very disturbed. Like I think you're proceeding with, I'll finish up fast. Like
No, go ahead.
yeah, please. Sorry. Yeah, can you able the screen sharing? I'll just finish fast.
Yes, ma'am. Can you please try again now?
Yeah. So these are the basic principles. Like, sorry for the disturbance. Like, I'm in my native, so little network disturbance is there. It's unexpected. Sorry. So we have to follow the informed consent. As we all know, there is an agreement. Informed consent is an agreement between the researchers and the participant. There must be a mutual commitment between the researcher as well as the participant. Both the parties should agree what has to be done. The templates are usually provided by the investigator, mentioning the details of the study to be provided in the vernacular language as well as in the English. So special circumstances such like vulnerable participants, we can have a legal representative, and for underage participants, the parent or the legal guardian should sign the consent form, and it is called as an assent. Like if there is problems with the literacy level, if the participant cannot sign, they can give the thumb impression and a witness must be present. The elements which has to be informed during the informed consent or the purpose of the research has to be explained very clearly to the participant, and the expected duration the participant has to be engaged in the research, and the description of any procedure which has to be done also has to be explained very clearly. And are there any foreseeable risks or discomforts has to be written, and it has to be explained too. Description of any benefits has to be done, and is there any alternative procedures or courses of treatment which, apart from the normal what the participant is getting, has to be explained very clearly, and we have to give assurance that confidentiality and the privacy will be maintained throughout the course of the research. Is there any compensation? If there is any problem, whom to contact? Usually the point of contact will be the principal investigator, as well as the ethical committee chairperson will be the primary point of contact, and their phone numbers has to be given to the participants in case if they have any pertinent questions or if they have any issues, they have to contact immediately. And it has to be stated in the informed consent that the participation is voluntary, and you can have the chance to refuse to participate or discontinue without any penalty in between the course of the research. Additional elements is the risks to the subjects, and if even not only the participant can discontinue, even the researcher can terminate their participation. Subject's participation can be terminated by the investigator, also has to be told very clearly. And if there are any additional costs to the subjects, and how many more participants are there without revealing their identity, that also has to be told to the participant. These are related to the consent. How do you get a consent? Like, consent has to be taken before screening, and it should be taken in written. Make sure that all the content of the informed consent is documented, is understood by the participant in the vernacular language. Ask questions if they want any more information. The language should be clear, simple, and non-technical. And the participant has to be given sufficient time. If they say, I go back and think and come back and give the signature, they have to be allowed. And comprehension, you have to ensure that they can. And now, even in between, it was being told that the taking of informed consent has to be video recorded without revealing the face of the patients. Like, how do you explain information? What do you say? Has to be video and audio recorded was the practice. So if consent is in therapeutic trial, consent has to be given by the subject themselves or by a legal representative if the patient is mentally incompetent, if there is physical incapacity, or if they are minors. Impartial witness sign wherever is necessary also has to be taken, and it has to be signed and dated. Thumb impression is also allowed. Like, in case of emergency, the consent is not needed, but the study investigator or the physician should state in writing to the ethical committee within 5 working days why such things has happened and what was the reason behind that. Fresh or reconsent should be taken if when there is a deviation of protocol, and if the patient was unconscious and the patient has gained consciousness, and if there is any modality or the procedures, sites, visits, and before publication also reconsent should be taken from the if necessary. So the document, as I said, have subject about his right for compensation, the contact details, and a copy of the IC informed consent documentation should be provided to the subject as well. It's not only should be with the researcher, a copy has to be given with the subject till they discontinue from your participation of the research. So what is the relationship among the researchers? Principal investigator is the primary responsible person who is accountable and answerable to the ethical committee and to the participants also. And there must be adequate training to the juniors or assistants, and they are also responsible to the research. And there must not be any discrimination between the participants, and the researchers should not mislead or force any other researchers to unethical practices. So there is something called as ICH for good clinical practices, which is a framework to conduct clinical trials according to similar rules and regulations to confirm high ethical and the scientific standards. GCP means good clinical practice. The purpose is to protect the rights of the research subjects and to ensure credibility of the data. So it is also applicable to prophylactic, diagnostic, and therapeutic trials, drugs, devices, and procedures, and the epidemiological studies. The players in clinical research, as we all know, primarily the investigators, then the sponsors, the regulatory agency, and most importantly, the ethical committees also. So if there is any discrepancy being found out in the clinical research, these are all the stakeholders who are answerable to the law and the court. Other ethical aspects to be considered are respect before, during, and after the research projects, honesty, frankness, personal integrity of the researcher, informed consent from the participant, confidentiality, anonymity, and courtesy on the part of the researcher to the participants. And once the research is done, ensure data plagiarism is not there, And when it is being published, you take care of the acknowledgement and the citation of the resources, as well as if there are any conflict of interest. So now these are the basic principle which is applied to the basic ethical principle which is applied to any type of research, and little more which is concerned with the translational research is the supervision of qualified health personnel is required in as well as in the T1 phase also. If it is in case of devising any new tools or new devices, even though it's not that biomedical engineering people or the health related technicians will be doing it, it has to be monitored with the super. That's what we say, that such a multidisciplinary, interdisciplinary projects where there are so many co-guides according to their experts. So that's mandatory. That must be a supervision of the qualified healthcare professionals and exhaustive analysis using consequentialist approach to minimize the risk of the subjects. Consequentialist approach means like in future, what will be the expected outcome? What are the things expected and what are the side effects or the benefits, or in terms of negative, what are the other outputs? Such translational analysis has to be done very exhaustively when we are bringing the bench to the bedside. And also we have to consider the social justice, that is the correspondence between where the research is done, by whom, and who are the beneficiaries. For example, if the research is done, if the research has to be implemented for example, in US, the medicine is being a small trial, that is T0 is being done in US, and T1, T through T3 phases are done in India. It's not, it should not be there. Social justice is there. So because when the T0 level is framed, their foresee is they wanted to implement that drug or the device for the US population. So all the other phases like T1 to T5 has to be done only in the US. Like if they should not be doing in the, so for the research or for the implementation in developed countries, the other phases of the translational things should not be tested in the developing countries. Like few things are being happening currently. Like that's what I have written it. Correspondence between where the research is done, by whom, and who are the beneficiaries. That's more important. Based on the beneficiaries, all the phases of the translational research has to. This is one of the most important ethical thing which has to be considered. The social justice. Equal should be treated equal and unequal as unequal. And the precautions in data sharing in the preliminary phases has to be considered. Like we should not be publishing it very confidently and very clearly, like in the preliminary phases at T1 level and T2 level, unless the data has been tested and it is tried at least to the till 4 level, the data has to be very carefully shared. So plan to translate the fundamental research to clinical practice and beyond by analyzing the potential effects, not only on the subjects, but also on the general level. So scientific research only when not at the cost of the ethics, and first of all, those of the researchers themselves. So that's it about the ethics in translational research. I'm sorry, like in between the net has gone and there was a little disturbance, and I hope the session was useful. And I thank the Society SFNP, the BioLeaks Worldwide, and the ITM University Gwalior for giving me the opportunity. Thank you.
Thank you so much. Really do appreciate it. Thank you so much for that presentation.
Thank
Doctor.
you.
All right, let's go ahead and proceed with our next speaker, currently working as an assistant nursing superintendent and assistant professor at Homi Bhabha Cancer Hospital. Mahamana Pandit Madan Mohan Malaviya Cancer Center. Varanasi Government of India, Department of Atomic Energy, and has 10 years of experience in it. She has a great academic record with gold medals in both UG and PG studies, undergraduate and postgraduate studies. She has been honored with many awards, which are Best in Charge Award 2016, Trauma Center, Banaras Hindu University, First Prize for Best Scientific Paper Presentation 2013, International Conference, Jipmer Puducherry. First prize, Best Scientific Paper. Oh, first prize for Best Scientific Paper Presentation, PhD Paper 2017. Wand Con, and many more. She was invited as international faculty representative from India for promulgation of Advanced Trauma Life Support Course in Bangkok. September 2019. She has also presented and published more than 25 scientific papers in international and national conferences and Scopus. High index journals, editor and reviewer in 15 high index international and national journals. She also has curriculum development for advanced oncology nursing courses. Let us welcome Dr. Rajni Sharma. Doctor?
Am I audible?
Yes, you are.
Oh, thank you, Jojo, for the introduction. And
ahead.
once again, a very good morning to everyone. Before proceeding, I'd like to thank organizer and ITM University for providing this wonderful platform for the presentation. So the topic assigned to me is healthcare sector challenges, issues, and opportunities. What is healthcare reforms in India? Healthcare reforms started around 2005 through programs aimed at strengthening rural health services and providing partial financial protection for healthcare to the vulnerable families. Fresh initiative proposed this year promised to open the road to universal health coverage. So the key institution component of the healthcare system in India are the state or government institution, healthcare providers, resource institution, purchase of healthcare such as insurance agencies, other sectorial agencies, for example, education, water supply, sanitation, consumers or population at large. Healthcare sector reforms components are healthcare sector reforms deals with equity, effectiveness, efficacy, quality, sustainability, defining priorities, refining the policies, reforming institution for policy implementation. Healthcare reform cycles begins with the problem definition, followed by diagnosis, implementation of the plan, then policy development, political decision, evaluation, and again the problem definition. This cycle goes like this, but the two major important components in this are the ethics and our political system. Challenges to the reforms. Basically, it is unclear who has the power and responsibility. The Minister of the Health, the medical association, health insurers, the citizen. The power divided among the group interest. Doctor wants more freedom and more resources. Health insurance want more control and less spending. Minister want quick changes, and the public health specialists focus on the health promotion. So these are the basic challenges to the reforms. Now the challenges in the healthcare sector. First is the population. India has the world's second largest population, rising from 760 million in 1985 to an estimated 1.3 billion in 2015. And in the past 25 years, India has added 450 million people over the last 25 years. Next is the infrastructure. The existing infrastructure is not enough to serve the need of the growing population. The public health care institutions are underfinanced and short-staffed. The doctor-to-patient ratio is dismal, that is 1:1700. The country has 81% short of a specialist at the rural community health centers, and the private sector accounts for the 63% of the hospital beds. Now you can imagine the condition of the government beds. Next is the rural-urban disparity. Rural India accounts for the 70% of the population, but account for only for the 30% of the healthcare services. This shows a huge demand supply gap in the rural areas. Private sector is highly concentrated in the urban in India, while the PSCs are short of more than 3,000 doctors. Next is the low government spending. So public expenditure on the health accounts only for 1.2% of the total health expenditure, which is very low when compared to the WHO recommendation of the 5%. So we spend only 1.2%, but the WHO recommends 5% of the health accounts. Next is the high output pocket expenditure. Out of pocket expenses account for 62% of the expenditure, which is very high when we compare it with US, that is 13.4%, 10% in UK, and 54% in China. Next is the insurance. So 76% of the Indian don't have the health insurance. Government contribution to the insurance is just 32%, which is a very low amount. Low insurance penetration and forces people to spend out of the pocket. Next is the dual disease burden. while the problems of maternal, infant mortality, communicable disease still exists, the lifestyle diseases like hypertension, diabetes are on rise. This situation has been termed as a dual disease burden. Lifestyle diseases account for half of the death in 2015. Malpractices in the sector, selling substandard and counterfeit medicines, unnecessary hospital admission and exploitation is the basic malpractices that is happening. Adequate attention has not been given to the alternative health practices like homeopathy, Ayurveda, and Unani. So if we work on the above this mentioned points, we can change, we can improve the healthcare sector in India. So what are the basic, these are the challenges, but now what are the basic key growth inhibitors? Delivery of the qualitative healthcare services is considered as a basic need, irrespective of the age, gender, and culture. Indian healthcare system faces substantial challenges in providing quality healthcare. The key growth inhibitors are fastest growing population, as we have already discussed, changing disease profile and re-emerging diseases in India, multi-layered healthcare system landscape, lack of or absence of the infrastructure, paucity of manpower, that are doctor, nurses, paramedics, extremely low public expenditure on the health, and inefficiencies and inaccessibility of the healthcare services. So if here in this graph, you can see how the population and urbanization is happening in India. So I've discussed already that we are the second largest nation in terms of the population, and we have added around 450 million of people in last 25. So you can see the growth exponential of the population. Also, if we talk about the rural and urban, so it is predicted that by 2050, the urban area will be more in India in comparison to the rural area. Now, changing disease profile. Here you see the percentage and the age group. So the diseases like communicable, non-communicable diseases, injury, and the other disease condition. Here you see how it varies according to the age distribution, which is really a very alarming thing. Also, if I talk about the disease profile, so cancer is one of the leading disease now in India, followed by heart disease, other circulatory, CNS disorder, diabetes, asthma, and so on. So here you can see, and the situation is really alarming. India, which makes up 16.5% of the world population and faces a significant burden of disease. It accounts of the third of diarrheal diseases, tuberculosis, respiratory parasitic infestation, prenatal condition, a quarter of maternal ailments, fifth of nutritional deficiency, second largest number of the HIV/AIDS cases in the world. Federation of Indian Chamber of Commerce and Industry, FICCI, India needs to spend around $203 billion if the mission of achieving health for all is to be attained. This is a prediction of the FICCI India. So non-communicable disease burden in India, if we see, cardiac patient are 50 million patient, diabetes accounts for the 63 million patient. Here cancer, if I talk about it, we are adding 1.2 million new cases every year. And stroke, 1.9 million cases every year. Renal, 1,75,000 transplants are required. So this is what is the present health condition situation in India. Healthcare reforms in India, a compelling need today. Some of the issues in our healthcare systems is lack of awareness, lack of access, workforce shortage, lack of affordability and accountability, unfunded healthcare system. A recent study by the Center of Disease Dynamics, Economics and Policy estimated that the India's total population of 130 crore, the country only has 1.9 million of the hospital beds, 95,000 ICU beds, 48,000 ventilators. Such a deep-rooted and extensive issue make in India frightfully vulnerable to healthcare crisis that has already happened at the time of COVID, like the one we are currently experiencing. So this is the present condition of the healthcare in India. The situation remains worrisome. In rural areas, about 66% of the Indian population reside. The doctor-to-patient ratio remains absolutely low, which is 0.7 doctors per 1,000 population people. This is compared to the World Health Organization, WHO, average of 2.5 doctors per 1,000 people. So 1,000, one doctor per 1,000 patient, that is an WHO recommendation, and India average is one doctor for 11,082 patient. Here, the total number of hospital beds is 1 lakh for 1 lakh population. Hospital bed for 1 lakh Indian population is only 139. Health expenditure per person among the BRICS and the other newly industrialized nation, India spends the least on the health per capita. Here you see the status of India. We spend only $75. So expenses cover out of the pocket expenses cover most of the healthcare expenditure in India. Here you see 70% is the private spending, while only 30% accounts for the public spending. This is a very small amount, and this affects the patient health and the family in India. Assessment indicators of the healthcare. India currently ranks low in Human Development Index, reflecting below per growth, education, and GNI. According to the United Nations India Human Development Report 2014, India falls at near bottom of the countries which have reached medium development and is ranked 135 among total 187 countries. While India has shown significant improvement in economic indicators such as GDP, the country is yet to improve the position on the Human Development Index, that is HDI. This is a slip of more than 15 ranks since 2010 from 119 to 135, reflecting a sluggish growth across all the three parameters, that is health, education, and gross national income per capita. It is continued. Next is the slow improvement in the healthcare indices is further reflected in India's inability to meet the Millennium Development Goals. While the country has witnessed, Shweta Kumari, please mute yourself. While the country has witnessed some improvements in the initial years, the progress has been suboptimal across the majority of the parameters over a period of time. So here, if we assess the progress sign and target description in the Millennium Development Goals, we can see under 5 mortality rate reduced to third between 1990 to 2015. It is still a slow progression. The maternal mortality ratio between 1990 to 2015 reduced by 3/4. That is still sluggish, slow progression. Have halted by 2015 and begin to reverse the spread of HIV/AIDS. It is achieved. Have halted by 2015 and begin to reverse the incidence of malaria and major diseases. There is no progress and regression. Indian government has launched multiple programs and development policies like national population policies, national health policies, national AIDS prevention and control policies, and the 10th 5-year plan to achieve the target set under the Millennium Development Goal. While this is still, government is still working on it. So let's see the improvement in the next phase. India ranks lower in the most of the health indicators when compared to its peer BRIC nations. So low healthcare spending. India spends less on healthcare than other middle income countries at 4% of the total GDP expenditure on healthcare in 2012. Spending in healthcare was half of that of the Brazil, South Africa, and much lower than China and Russia. Public share of the healthcare expenditure remains low. Public spending on the healthcare in India is only 33% of the total healthcare spend. With only 1/3 of the coming from the government, India ranks 184 out of 191 countries public spending on the health. Low life expectancy. Despite progress over the last decade, life expectancy at the birth in India remains low. With many state health systems suffering from the shortage of spending and shortfalls in the management, significant population is left without quality and affordable care. IMR is still among the highest among the peers. Even with the healthcare advancement and the government programs, IMR is still India when compared to the emerging economies. The majority of the issue from preventable situations such as preterm birth complication, lower respiratory infection, and a diarrheal disease, which accounts for 21% of the years of the lost due to disease. Maternal health safety is still an issue. India still accounts for 20% of the maternal mortality death in the world, with 190 deaths per 1 lakh of the live births. This is the Another graph showing the health as a low priority. So here we spend only 1.29% of the GDP in 2019-20. In 18-2, the country has lagged behind the BRICS peer as well as developed nation. Next is again continue with assessment indicators of the healthcare. The weak growth in improving the infrastructure and the human resource strength has among the main reason for India poor performance as compared to the developing nation. Human resource shortage is one of the reason. The condition deteriorates, human resource shortage, that condition deteriorates as one move from urban to the rural areas. About 80% of the doctors, 75% of the dispensaries and 60% of the hospitals present at urban, while 72% of the Indian population reside in the rural areas. Increasing affordability issue, rising healthcare cost is another major concern in India, with around 60% of the healthcare is being expenditure out of the pocket, and around 39 million of the people are pushed to poverty every year because of the health in India. So low insurance coverage, as I've already discussed, only 76% of the population is not covered under any health insurance scheme. So 10 points to improve of the healthcare system in India are affordability, accessibility, availability, acceptability, prioritization, doctor-patient ratio, workforce, public-private partnership, health insurance quality. So if I talk about affordability, reasonable cost of the medical services for the economically weak people, free health camp should be promoted by the government and the public hospital. Accessibility, healthcare centers should be situated in the central place where there is a good transport services available. Patient-friendly mobile application, which enables the instant contact with the doctor, should be encouraged. Access to technological devices, applications, and the medical information should be promoted by the government of India. It is already very well working in the other foreign countries. Next is the availability. Healthcare centers should possess well-equipped medical facilities. Most importantly, availability of the multi-speciality doctor 24/7 should be ensured by the government. But unfortunately, we are lacking with the shortage of the manpower. So it is still a difficult situation. Acceptability. Patient acceptability is an essential tool for promote the good health. Patient acceptability can be ascertained by the good interpersonal skill of the doctor. The physician should make a patient understand the importance of health-based technological advancement. Next is the prioritization of the patient based on the nature of the health issue. This is very important component. So the accident and emergency should be given first priority, followed by geriatrics and pediatric age group. Patient who is not critically ill in the outpatient department or get treated in the daycare. By following such system strictly, we will be able to manage the healthcare needs for the all. This should be strictly followed, and if we plan or if we triage properly, means the burden can reduce much in the government hospitals. Next, if I talk about doctor-patient ratio, so India has one doctor for every 1,681 or that is 1,700 present population. Effort is to be made jointly by the government and private sector to improve the doctor-to-patient ratio. Reservation for the medical seat should be removed. Medical seats should be available at the reasonable cost. Workforce and human resource. The human resource technique to employ the people should be improved to increase the employees in the medical fields. Better wages, awards, promotion, and standardized yearly salary hike should be promoted by all the government and the private hospital and the medical college. Next is public-private partnership. Over the recent decade, there has been an increased affinity in the growth of interest in the public-private partnership of the health in India. PPP are the form of long-term contract between the government and the private entity through which the government and the private party jointly finance the public services. The awareness about the PPP must be encouraged through the medical education in a various institution. Conference related to public-private partnership should be conducted yearly. Next, the very important thing, the health insurance and social health care. So enormous efforts have been made to enhance through digital healthcare in India. The out-of-pocket expenditure on healthcare is about 85.9% according to the World Bank. Health insurance in India can be improved by equal importance has to be given to cover the primary and secondary healthcare needs under insurance scheme. To deliver the insurance scheme more effectively, it should be backed up with the technology so that citizens have an easy access to the healthcare schemes. All insurance companies should cover pre-existing disease. This is actually not happening in India. So many insurance policies are not covering the pre-existing disease and some of the chronic disease. They have their own criteria, which is again making patient to spend out of the pocket. The waiting period for the approval of insurance should be minimum and should not cause inconvenience to the patient. If I talk about the quality of the medical care in India is on the decline due to the shortage of medical professionals, poor infrastructure, poor information technology, and poor quality of medical research and survey. The quality can be improved by the focus on increasing the number of doctors and paramedics, improvisation of infrastructure in hospital, improvisation of healthcare information technology, and quality research and survey. Now, the opportunities in the healthcare sector. National Health Policy 2017 recommended the increase in the public expenditure on health to 2.5%, which should be adhered to. This could help to reduce out of the pocket expenses. Focus of primary care. India needs to shift focus from secondary and tertiary sector to primary care. PSC should be made attractive to the doctors by providing incentives and making rural services mandatory for the medical student. I think it has been already made by the government. Focus should be shifted to prevent healthcare from the curative healthcare. Universal immunization help to reduce the incidence of communicable diseases and reduce the cost of the curative care. Private investment in education institutions should be encouraged. This would help increase the number of graduating doctors in year and address the problem of doctor-patient ratio. Niti Aayog also recommended the same. Proper implementation of the initiative like Rashtriya Swasthya Suraksha Yojana is needed to increase the insurance penetration. A national health regulatory and development framework need to be made for improving the quality, performance, equity, efficacy, and accountability of the healthcare deliveries across the country. It should be put out standard treatment guidelines for the public and the private providers, frame a patient charter of rights, engage with professional association and civil society to establish a regular audit system. It should be put out standard treatment guidelines for the public and the private providers, frame a providers. The government and the National Innovation Council, which is mandated to provide a platform for collaboration among the healthcare domains experts, stakeholder, and key participants, should be encouraged and culture of innovation in India and help to develop the policy on innovation. Establishment of the Ministry of Ayush provides an opportunity to explore the alternative medicine practices. Ayush system should be made mainstream in the healthcare along with the allopathy. Research and development should be encouraged in these domains and the awareness need to be created among the general population. Next is the leveraging the benefits of the information technology. Computer and mobile phone based e-health and m-health initiative were launched by the World Health Day in 2016. This includes the Swasth Bharat mobile application for the information on the disease, symptom treatment, health alert on tips, Anmol ANM online tablet application for the healthcare workers, e-Rakt Kosh, a blood bank management information system, India fights dengue, leveraging the benefits of the information technologies and which also helps in enhancing the quality of the service of the delivery. Next is the investment from the startups. Startups are the investing in the healthcare sector from the process of automation to the diagnosis to the low cost innovations. Policies and regulatory support also should be provided to make healthcare accessible and affordable. Next is the data analytics. So big data analytics could be help in tracking the patient treatment and prescription. It is going to be very beneficial for the patient, especially if we have to cover the large population with the short of manpower. Spreading awareness about the non-communicable diseases. It is very important, like information for the diseases like hypertension, diabetes, healthy lifestyle should be promoted with yoga and medicines. Active participation in campaigns helped in the eradication of the polio, and success was achieved in reducing the incidence of HIV/AIDS by providing information and spreading awareness. Similar strategies can be used for containing the spread of the diseases like tuberculosis and dengue. Working towards the universal health coverage, India should take a cue from the other development countries like Thailand, who work towards providing USC. The UC includes the three components, that is population coverage, health coverage, and the cost coverage. So here the new high potential HSR, health sector reforms initiative by the government of India. The first government initiative is a telemedicine, and the purpose was to serve the combines information and communication technologies with the medical sciences for the clinical record, diagnostic test, video consultation, medical education. The issue addressed with this telemedicine India is to increase the healthcare services and education, rural and remote parts under the emergency condition. Next is the compulsory licensing. Grant of non-patent holders permission to manufacture patent drugs is not available and affordable price. The first grant, cancer drug Nexavar, in March 2012, it is granted. So the issue addresses to increase the accessibility to the medication. Next is the Bachelor of the Rural Healthcare. This is a course, BRHC. 3.5 year of the rural healthcare course proposed in Rajya Sabha. This course is proposed, and the issue addresses to increase the rural healthcare professionals. Next is the National Program for Healthcare of the Elderly, that is NPHCE. The purpose is to serve to be test launched in 100 districts for the country in 2012-17. The issue address is to reduce the incidence of non-communicable diseases in elderly. Next is a national program for prevention and control of cancer, diabetes, cardiovascular diseases, and stroke. It to be test launched in 100 districts of the country in 12-17. The issue addressed is to reduce the incidence of the major non-communicable diseases through lifestyle modification. Next, the free medicine for all, rupees 28,560 crore plan to provide 348 medicine for all must prescribe generic drugs mandate to the doctors. And the issue addresses to increase the accessibility to the medication, also reducing the cost of the medicines. Healthcare for all by 2020, the resident will have the healthcare coverage via combination of the public, employer, and private resources. The issue addresses to uphold the fundamental right of all the citizens to adequate healthcare. Now, conclusion. Reforms encompasses a range of a purposeful effort to change the system for improving its performance. You should make a deliberate efforts and conscious choices so that the changes in the system would lead to improved performance in line with the desired goals. Reforms have to be rational, logical, and specific. Healthcare sector reforms is a political process. And everywhere, radical reforms is impossible without robust political leadership informed by a sound technical advice. Reform should take place as a sustained process of fundamental changes in the health policies and the health institutional arrangement. Healthcare sector reforms demand an explicit link between the researcher, planners, and a decision maker for the optimal use of the research findings. Also, while every reform experience is country specific, there are always important lessons to learn from comparing options, identifying common issues addressed and the tool used, and evaluating the effect of various reforms initiated. Now, I am winding up with my presentation. If you have any question, you can please ask. Thank you.
Thank you so much. Thank you so much for that presentation. And let's go ahead and proceed with our next speaker. Doctor completed PhD from MGMIHF, University of Samoti, Navi Mumbai, and master's degree in nursing at the SNDT Women's University, Mumbai, India. Presently working as professor cum vice principal at Tata Memorial Hospital College of Nursing. Member of Board of Studies affiliated to HBNI University, Grant in Aid Institute Nursing Fraternity. Like member of Trained Nurses Associated of India and has worked as secretary for TNAI or Navi Mumbai branch. Has published more than 10 scientific papers, 21 presentations in the national and international conference. Let us welcome Dr. Manisha Nankumar Pawar. Doctor?
Yes, ma'am. Full, you can see the slide now.
Yes, go ahead, please. Have it in presentation mode, doctor. Proceed.
Slideshow आहे. Good morning to all the respected dignitaries and greetings to the third international conference on nursing science and research. On nursing science and healthcare, organized by Society of Nursing Practices and ITM Gwalior College of Nursing, India. Dean Professor Mini Anil, Professor Dr. Sudha Rani, ITM Gwalior College of Nursing, India. Chief guest, Dr. Jati Balachandran, Assistant Director of Nursing at Government of India, Ministry of Health and Family Welfare. All the respected dignitaries, speakers, and experts from all over the country. And my special thanks to Mr. Vignesh and Mr. Gopinathan and the full team of Society of Nursing Practice. And thanks for the introduction, Jojo. Yes, transition can be achieved with meaningful health outcomes and overall being through translational research. The nursing management has changed over time and translational research is a priority. Competencies of professional nurse in order to render quality nursing care with difference, we need transition of clinical research into clinical outcomes, into innovations and initiatives that can enhance nursing care. Reforming healthcare system, transition of clinical research into clinical is the theme for today's presentation. I'm indeed honored to participate in this conference to provide a unique window of perspective on true nature of transition of clinical research into clinical. This is a challenge for us to see clearly what lies beyond the data and the number from various researchers that we can have today. The unprecedented attention provided by nurses to transition of clinical research into clinical is the platform of our opportunity, which reminds me the passion that had happened years deep root way back into the nursing profession. The term translational research is not a new term in the field of nursing. It has a very deep roots way back in early in 90s and 1960s and 70s when G. Johnson was talking about translational of research into practice. We moved to talk about research utilization using research into practice and then in all the professions. We kind of morphed into in 1900 and 2000s in talking about evidence-based practice. We tend to talk about it in whatever our profession is. So we have evidence-based medicine, we have evidence-based management, we have evidence-based nursing, we have evidence-based public health, and so on and so forth. But it's really about evidence-based practice. And now we have come to the full circle. We are now again talking about translational research. So to go about, I have been impressed with this proverb by Leonardo da Vinci. The urgency of doing. Knowing is not enough. We must apply. Being willing is not enough. We must do. This impressed me a lot in translational research, so that what translational research is, translational research is a long journey starting from bench to bedside, the journey which moves from scientific lab ultimately to the hospital, giving beneficial benefits to the community and to our people who suffer from specific diseases. It can be either a drug or a medical device or a diagnosis or anything. So this picture which I have shown you, this shows you about many problems are surrounding. And so we have many existing problems right now. We have to go with COVID pandemic situations. So many scientific organizations, scientific labs are proceeding with different vaccine kits, drugs, etc. to find solution for this pandemic problem. So now we are going to relate this, and Agency for Healthcare Research Quality Improvement Series found out the value of translational research products. Though the health system panel, what did they find out? They say there are a lot of gaps and numerous research is being conducted. But there is a huge sum of money, the cost designated to research via funding, via support, via means of research. However, very few research end up in practice. So, do we have best evidence for the translational research? There is a need for the strategies to overcome these barriers. Implementing evidence-based practice is a challenge and it's a change, and we all need to adopt that. We are ready to distill and communicate actionable evidence. We may have many evidence, they may be statistically significant and coherent with clinical cognition, but there is a need providing most timely and current evidence, what we say right now. 5 years evidence in academic setting, we do not have evidence to use for any supporting evidence more than 5 years. So what does this? It means our policies, procedures are changing every 5 years. Clinical settings dynamically change. Therefore, evidence needs to be current. Anything more than 15 years or even 10 years evidence is considered as an expired evidence. So in this research where it is, you can see the slide for basic and applied research, and between this is the translational research. So basic research is nothing but a desire to expand the knowledge. It is curiosity driven. It's intended to answer why and what and how the presence, increasing the fundamental understanding of the principles, but does not have an immediate commercial objectives. It may not be necessary result in an invention or solution to a practical problem, but it answers only fundamental questions. But the basic research leads to new products, technology, and process. And applied research is, so the name suggests, is an applied new knowledge which is acquired as a specific commercial part, and so is the commercial value. The objectives can be products, procedures you have invented, a new protocol or diagnostic kit, or any type of service. So your applied research gives you answers to the specific questions aimed at solving the practical problems. So here we are going to create new products, technologies, and processes. So this leads to new fundamental questions. And these are the two types of researches that happens in the community. So what is this translational research? The translational research happens to be a bridge between the basic and the clinical research. And it is the form of the research that becomes beneficial to the community. So bench to bedside process that uses knowledge from basic scientific research into clinical research to create novel treatments and any treatment, new treatments option device and preventive diagnostic, which is forming the bridge between the basic and the clinical research. As we have already dealt with this particular slides, I'll just go in short with this. As we know about the translational research, and there are new drugs which enters into the market, and it takes more than 6 to 8 years to around 11 years. So the path that is going to travel across the entire path is called as translational spectrum, and this spectrum involves the phases T0, T1, T2, T3, and T4, which Ma'am Ponchitra has already discussed. But the significance of this translational research is multifaceted, and it's a balance factor between the bench science and the population science, and it involves the private health institutions, public health institutions, governmental institutions, and voluntary institutions, and also involves the interdisciplinary collaboration to do the translational research. And there is a gap in all these stages of translational research concept. So there can be a gap in medical practice if the evidence are not communicated, which is present right now, and there is a huge gap and there is a huge gap between evidence and practice currently. What they say, evidence, once it comes, it goes to not all the evidence goes into practice. If at all they end up in practice, it takes about 15 to 20 years ago. So now it is 10 to 15 years currently that two huge evidence can become expired, and that's the gap. That is a predominant half that is not published. So it's not disseminated, it's not translated. So translational research is a pivotal point for evidence practice, which is lacking. And this is the valley of death, which is the most important part, which leads to be this translational research converting the valley of death into the Garden of Eden. And this is defined by the pharmaceutical industry, which encompasses, if you see here, this valley of death is very important, and it encompasses the T0 to T2 phase of the research. So this transition continuum should proceed. So this valley of death should be crossed by a group of people who are converting this basic research into advanced into translational research. So what should be done? The main thing is we need to remove the physical barriers that is blocking our collaboration. So basic research people or the basic scientists have to collaborate with transition scientists, and they should work together and provide access for adequate funding. Funding, infrastructure, everything is needed. The access to these should be provided. Only then the value of that will be prevented and we can cross those hurdles. So there are war holes in the system, and these are the some where there is shift from acute to chronic condition, aging population growth, global health disparities, emerging and re-emerging infectious diseases, emerging non-communicable diseases, and depression, allergy, obesity. Already Dr. Rajni has mentioned and discussed in her talk. These inequalities which are we fair today, those have even reached beyond the normal expectations, depriving the marginal sector and the right to live within the bound of the discomfort. The 2017, the national demographic results showed the increasing mortality, infant and under 5 mortality rate. The coverage of this finance insurance remains in times of clarity and health disaster is an important issue. All these scenarios are compelling and overall war holes in the health system, and these needs to be addressed, implemented, and very strong decisive interventions needs to be taken. So the need for translational research is very important, and this needs to be taken up by removing the knowledge practice gap. So this initiative was taken up by Barack Obama, mentioned what precision medicine is. Each individual, each patient is unique, and doctors are always trying to tailor their treatments as best as they can do as an individual. So you can match a blood transfusion to a blood type. That was very important discovery. But what if matching a cancer cure to a genetic code was just as easy and just as a standard? What if figuring out the right dose of medicine was as simple as taking our temperature? So far as these problems, these are being very complex. We cannot measure them as easily the way you do any blood test or you do any temperature measurements. So, but if the individual therapy learns precision medicines be possible, which looks like going to be the reality now, will become very different. So this knowledge practice gap, the knowledge driven model was used within the medical field, assumed that basic research would progress to applied research and would eventually lead to development stages such as new medicines or technology, and then the application in the realm of practice. Example, it took 200 years for convincing the cure of scurvy. And these are some emerging models which are the future of translational research in nursing. And this emphasizes the interaction between the researchers and the decision makers in developing the implementing research in practice. Nurses must engage immediately and assertively in settings and agenda for translation of their research into practice in healthcare system and to the public. In order to achieve this, nurses need to focus on 3 sectors: traditional, mainstream health service, including the complementary and alternative health service, and community health service and general public. Nurses must be visible and vocal on focusing on the areas in which nurses have expertise. Nurses should expect that they exist, embrace, advance, and translate nursing science, given that nurses have been contributing in the clinical areas. Nurses should make translational science models visible, and their efforts should be supported by federal agencies. Contemporary communication medias have a great reach, and nurses should use them more effectively to promote health and healthcare. Nurses need to author articles and books for public and contribute to the internet sources designed to translate research finding to public for their benefit. If nurses are truly committed to translation of research in practice, they will resolve to educate clinicians who are capable of translational work necessary to truly achieve this goal. So this evidence-based movement, if you remember, in February 1996, a group of pediatricians and obstetricians in Manila gathered to conceptualize a study that would establish the incidence rate of metabolic conditions in the newborn. They were hoping that the resource will fall apart upon the policy recommendation for the whole country. They took careful initiative and all the necessary hard work to link the people in proper authorities in making research a success. Blood samples were taken from study participants and were even sent all the way to New South Wales, Australia for the test instruments and analysis. 2 years later, when had a breakthrough results, the research slowly to become a model of public health victory. This was the first successful population-based genetic screening that integrated with public health sector. That research has now evolved to what we know today as newborn screening program. And from an initial start, abruptly 11,000 infants were screened back in 1996. We have already provided early screening of metabolic diseases and detections for a total of 10.6 million infants born in the country. And we may not be aware, but almost of all the health services that were made available to the public stated from research initiatives by the best minds country has ever produced. So focus the two-way nature of knowledge flows and the need for active engagement rather than passive diffusion. Rather than assessing knowledge flows safely by the efficiency of the outcomes, the conceptual focus shifted on the process of interaction and collaboration. Also, while evidence-based medicine reconciled the violation variations involved in the problem selection and analysis through the logic of efficiency, the emerging conceptualization of knowledge exchange considered and reconciled cultural differences in the symmetrical and reciprocal interaction of researchers and practitioners. So take this case of this epidemiological studies more than 3 decades ago. The basis of national immunization policy in providing newborn of hepatitis B vaccination protected more than 2 million infants from developing liver cancer today. Research and resources of research from the food and nutrition became the foundation for the policy for the food fortification to combat this dreaded consequence of malnutrition in our society. These and many more researchers were born out of dedication and passion at the time to a need tremendous change in human life in challenge. This is the true nature of translational research. It is the broader in form and characteristics by taken more systematic efforts, systematic approach to convert the basic research knowledge into practical application to enhance human health and overall well-being. Expanding research literature being difficult to access in timely fashion, the gaps in the current understanding of health and disease process and the difficulty of interpreting the results of research publications, there remains also the tension of conjoining knowledge base from scientific research community with that of clinical communities. Today, we are all forced with many challenges that are evolved with levels of difficulties over years and gradually becomes the barrier to achieve the better health outcomes. So the strength of the clinical research, as we see from this picture, is we need to approve the existing strategies and overcome all the barriers and hurdle. We need to critical information to move the whole health sector. As the steward of health investment, desire and belief, there is no scientific inquiry better placed than the translational research to fuel and progress to speed up the development in health. Health research inconsistencies have been the most impressed by the manuscript turning into policies are the sustainable interventions, because in fact, how we are confronting the growth stumbling blast in making the data and the number into practical solutions that would map over the way for the region and the whole country. Remember, the true progress in the health research is mainly measured by the data. and the scientific inquiry, it can waive just to entertain curiosity and intellectual side alone. But it's well measured by the change it creates and makes life better than it was before. Translating data into interventions during these challenging times would require more than critical thinking, but also influence the key players in the system. So to multidisciplinary approach and the teamwork is needed to strengthen this research. And if you want to go fast, you can go alone. If you want to go far, go together. So with this proverb, as a team, where the characteristics of translational scientists is important. So we need to have one boundary crosser, a process innovator, a team player, a principal domain expert, a skilled communicator, system thinker, and a rigorous researcher. So a boundary crosser, so you should break down the disciplinary silence and collaborate with others. Your team will have physics, chemistry, biotech person, a genetic person, and a physiology. And so if the multidisciplinary team should be created with the process innovator. And this needs to create with the profession to collectively pass and develop the medical intervention, and whatever the ideas have to be discussed, and then it has to be proceeded, and then you should go to the team player. This team player is very important, so that the value of the contribution for these players, each one will contribute to the disciplinary team, and each one will contribute as a part of the principle of domain expert. You cannot be a domain expert in all the areas in your area. So you can discuss the innovation with the other disciplinary and get better understanding through the journey. The skilled communicator communicates with the understanding with all the stakeholders in the translational process across the diverse social, cultural, economic, and scientific background. And the good system thinker needs to be so whenever the time permits, you have to share your innovation with different bodies and with the investors, with the speakers to the translational process across. Then you should be a good system thinker. So these are the characteristics of the nurse scientist. So the translation, we said it's a process you're going across. And so the scientific lab to the preclinical trials and ultimately into the community. So the success of the trial again depends on a team. And whenever there is no individual person involved, here you require a team, the sponsor, the principal investigator, the collaborator, the pharmacist, the nursing personnel, the regulatory board, the data manager, that including the statistician will give a successful and will finally evolve a successful clinical trial, again, a multidisciplinary approach. So this impact of this translational results may not always seek well. The people in the authority need to transform the result to concrete and practical solutions that will instill within the minds of the key players the sense of need, urgency, and practicality. So as you see, the insulin was originally isolated from canines in 1920s, and porcine species was used to generate the insulin analogs for the use in the humans. The animal insulin could cause allergic reaction in some patients. So the insulin was purified from human cadaver, and all of these methods were resource limited, time consuming, and costly. So in 78, the genetic technician genetically manipulated E. coli to produce human insulin, and this was the first recombinant human insulin which was approved by FDA in 82, and these compounds are identical to the physiological insulin and can be further modified to have after effects, which got the Nobel Prize. So they must feel that your research data is the last missing piece to finally achieve the most coveted outcomes. And that's why this Nobel Prize was given for this. Again, there are the needs. For the needs-driven innovation in translational research is to need to hold on the perseverance and the sense of support. When we started research inquiry, you will face a lot of hurdles, even rejections, but it must never discourage you. And that's why all these, where there was no non-invasive scar compliance assessment and this full thickness grafts, adipose tissue excision This is mainly for the burns wound management. There is also a smart device which has come up, which is based on burn size assessment and imaging. And this is through the for the wireless automated insulin protocol adapter. So these are all the new driven innovations which encourage us to take up different topics and do the researches. Also, as I had mentioned you about this metabolic screening, if what would have happened if the researchers in that 1996, if they have loosened the track of the directions and determination and missed the opportunity for the push of this legislation of newborn screening program of metabolic disorders, millions could have succumbed to mental retardations today, but they never lost hope. So it was an assured journey, and it took them around 8 years to have successfully enacted by the Congress and passed by the law. So today, the Department of Health and is redesigning and streaming practical strangers to accelerate health outcome as a part of commitment to achieve meaningful well-being of every citizen. Need to call on researchers that can help in mobilizing resources, physical autonomy, and focusing financial resources towards high-impact interventions, especially in primary healthcare delivery. Strengthen and welcome in scientific inquiry and evidence-based interventions that can help in increasing the access to quality health, essential health products, services that will prevent pandemic, communicable, emerging, and re-emerging diseases which are occurring in the country. We need to look into expanding our services, deliveries, and network to finally link and coordinate to link referral systems in the grassroots levels. We need to develop innovations that will support capacity building of the staff and streamlining regulations in the health, and look forward in the risk and outcome in strengthening the entire system. All these are potential areas that transformational research can address. We must keep in mind that weakness and failures in transformational research to health policies actions can be one driving force that needs people to poverty, sickness, and even death. Because we fail to transform the need piece for information that will strengthen the foundations of healthcare system that caters to them. So in conclusion, I will just end by saying that when we talk about translational research, however, there is no magic bullet for translating what is known from research to practice. We can look at it from two perspectives. As a process, it bridges that it is a linking bench research with clinical research and clinical research with health practice in community. And as an outcome, it can be conceived of our destination improving the health to the public. I remember the tremendous potential bringing this in this conference today. Never have seen such a virtual gathering that changes the landscape of the health, that will host the scientific change of health in the years to come. Thank you for the platform, for the scientific exchange, for the future healthcare. Ladies and gentlemen, we have all seen the true capacity of translational research in achieving meaningful health outcomes and well-being. It has been done, it can be done, it will be done again. And thank you very much and good day.
Thank you so much, Doctor. Right, and let's call on our next speaker. Started teaching career in 1999 as a lecturer in Omayal Achi College of Nursing, Chennai, Tamil Nadu. She holds PhD in mental health nursing from Savitha University, Chennai, Tamil Nadu, since 2016. She has appointed as the principal College of College of Nursing Sciences, Dayananda Sagar University, Bengaluru in October 2018. She is supervising several postgraduates and PhD scholars Let us welcome Dr. Sharmila. However, she will not be able to join us today. And also our keynote speaker, Dr. Salwa El Sayed. She's currently working as a professor at the Department of Medical Surgical Nursing, Faculty of Nursing, Fayum University, Egypt. All right, everyone. Let's go ahead and proceed with our technical sessions. So we will be having, I believe the breakout rooms are up already. So we will be having two parallel sessions. Parallel session 1 is about nursing research or OBG. In parallel session 1, please stay in this main room and I will be your moderator. Now, parallel session 2, nursing and healthcare. Just go to the breakout room and click on nursing and healthcare. If you are having problems, please do shoot us a message in the chat box and one of our technical team will transfer you or move you. Oh, I believe since we only have nursing and OBG. I apologize. Nursing and OBG will be here in the main hall. Nursing and healthcare is on the breakout room too. Please proceed. All right. Technical session 1 is again about nursing and OBG. And let us welcome our session chair, Dr. Gopi, Associate Professor, Sri Manakula Vinayagar College of Nursing, India. Sir, would you like to say something? Give them an inspirational speech, ma'am.
Yes, ma'am. Good morning.
Morning, sir.
Congratulations for all the participants for the oral presentation. I think you can start the presentation.
Thank you, session chair. All right, let's go ahead and proceed. Parallel session 1, nursing research OBG. Our first oral presentation by Babita, Government College of Nursing, Calicut, India. The topic is about the prevalence of postpartum depressive symptoms among mothers. Babita? I can't hear you. Is it just me or I can't hear her? Can anybody hear her? I'm sorry, but I cannot hear you. Are you using a headset or an earphone? No? We cannot hear you. Can you remove your headset and see if your computer can detect your voice? Hello? All right, we'll give you time to fix that, and I'll call you after, all right? Let's proceed to our second oral presentation by Miki Khan from Rufaida College of Nursing, Jamia Hamdard University, India. Her topic is the topic is about a comparative study to assess the anemia in primigravida and multigravida antenatal mothers in selected hospital of Delhi. Miki?
Good morning.
Miki Khan?
Good morning to all of you. Am I audible?
Yes, you are, ma'am. Thank you. Please proceed.
Okay, first of all, I would like to express my sincere thanks to the organizer who have given me the opportunity to present my topic. Now I'm going to share my screen. Ma'am, I'm not able to share my screen.
Oh, hold on. Go ahead.
Okay, fine, ma'am, fine. No, it's not open. I'm not able to share, ma'am. Am I audible, ma'am?
Yes, you are audible.
Ma'am, I'm not able to share my screen.
Yeah. Gisela? We're having problems. Gisela?
Yes, yes, ma'am.
Can you give access to Dr. Miki Khan?
Ma'am, I'm trying to share my screen, but I'm not able to share.
Ma'am, can you please try again now?
Okay, okay.
Yep, we can see it now. You can go ahead and proceed.
My screen is visible to all of you?
Yes, it is.
Okay. Now this is visible to all of you, my screen?
Yes, it is. Please proceed.
Okay, okay. So when I want to present the comparative study is the anemia in primary gravida and multigravida antenatal mother in selected hospital of Delhi. Anemia occurring during the pregnancy is an important public health problem developing in countries, in India, anemia is one of the most common causes, around 20% to the total maternal death. Anemia, India was the first developing country to take up a national program to prevent anemia among the pregnant women. The National Anemia Prophylaxis Program of iron and folic acid distribution to all the pregnant women in India through the primary health care system, and it was implemented in 1972. 500 microgram of folic acid was hoped that this program will bring about a reduction in the prevalence and severity of the anemia in pregnancy. One of the component of this program, pregnant women should receive 60 milligram elemental iron tablets. According to the WHO recommendation, the hemoglobin level, it should be 6 to 12 or up to 1 to 5 years of age. It should be more than 11 gram per dl. In adolescent girls, it should be more than 12 gram per dl. Women reproductive age, it should be more than 12 gram per dl. Pregnancy, 11 gram per dl. Lactating mother, 12 gram, more than 12 gram per dl. So that is a recommendation which is given by the WHO. WHO did program manager. They have done the study of 75 booked antenatal mother age between 19 to 40 years and with gestation age of 27 to 40 weeks. They observed that 75 antenatal mothers, the hemoglobin level was less than 10 gram percentage in 83 cases, and it was more than 10 in 17% cases. Iron deficiency anemia and dimorphic anemia were recorded in the 37 and 19% women respectively. Neither the iron deficiency anemia in pregnancy is a risk factor for preterm delivery and subsequent low birth weight, and possibly for inferior neonatal health, thus providing some protection against iron deficiency in subsequent pregnancy. In case the maternal iron deficiency in pregnancy reduce fetal iron stores, perhaps well into the first year of life. By tracking maternal anemia with evidence-based intervention, we can prevent the occurrence of other medical complications for the mother and newborn, like congestive heart failure and kidney failure. The objective of the study were to identify the determinants of hemoglobin concentration before pregnancy, during pregnancy, and after labor. Study was conducted with the aim of evaluating anemia among the booked primigravida mother, multigravida, antenatal mother during the last trimester. Now, my objective for the study was to assess the HB level in primigravida mother, to assess the HB level in multigravida mother, to compare the HB level in primary and multigravida mother, and to give health education regarding the anemia. If mother, they are anemic, so how can they improve their HB level and prevention of anemia? Now, if we just see reviews of literature, there are so many reviews are there which shows if mother, she's having anemia, so it will going to affect the health of the mother. So William MD et al. Done the study. Severe anemia has adverse effect on mother and fetus. There is also evidence that less than anemia is associated with poor pregnancy outcome. Major maternal complication directly related anemia are not common in women with hemoglobin level than if they have more than 6 gram of hemoglobin. However, if the HB level is less than, so it will going to cause a significant morbidity in pregnant women, such as infection, increased hospital stay, other general health problems. Now, another study which is done by FLESA, a lot of symptoms and sign and symptoms can be seen clinically. So they are vary from person to person or like to the level of the HP. So these common symptoms are headache, fatigue, lethargy, paresthesia, and clinical sign of tachycardia, tachypnea, pallor, glossitis, and cheilitis. So these are the things, these are the problems which mother can have if she is having a anemia. Now, certain study also have been done on effect on fetus. If mother, she's having a anemia, how the baby will going to affect. So that study was done by MCFE, JG. It is important to know the iron status of the fetus for definitive and corrective conclusion about the management. There are several reports correlate the anemia during pregnancy with the prematurity and low birth weight infant, indicating a relationship between low birth weight and low maternal HB. Now, another study which is done by Kelter F et al. Large epidemiological study was shown that increase in 20% with HB between 10 to 11 gram DL and 60% pregnancy HB between 9 to 10. So if mother, she's having anemia, moderate or mild anemia, she may have a chance for the preterm deliveries. Now, conceptual framework which I have used, that is a nursing process. So in which I have done the assessment of socioeconomic condition of the mother. I have taken the data regarding age, education, working status, income, and I have taken trimester, second, third trimester, and laboratory investigation was done for the HB. Planning, I have identified the demographic data, and then I have find out the HB level. And if they have iron deficiency or anemia, so I have planned for the health education to the mother. Now, this is a schematic representation of my study. My research was descriptive. Design one non-experimental design setting. It's a government hospital in Delhi. Sample I have taken 200 sample, 100 primary gravida mother, 100 multi-gravida mother. So 200 sample I have taken. Now my sample technique was random sampling technique. Sample size 200. Data collection was structure interview schedule was given, and hemoglobin estimation were done, and analysis was done descriptive. So I have taken the data of the mother. It shows that most of the mother, they fall in the age group of 21 to 25, and they are 23%. They are less than 10th, standard education, and 10 to 19 standard education, and most of the women, they are non-working. So 92% women, they are non-working, and 8 women, they are working in primary gravida mother. And most of the mother, they belong to Hindu religion, and they all are from 3rd trimester. When I have done the assessment of their hemoglobin level in primary gravida mother, so I have categorized into 3 types: mild, moderate, and severe. So 20% of the mother, primary gravida mother, they fall under the mild category, and 71 under the moderate category, and 2 will under the severe category. So now this is the data of multi-gravida mother, demographic data of multi-gravida mother. So in which 55% of mother, they fall in the age group of 21 to 25, and majority of, and then 26 to 30, they have 34%. And education, most of the women, they have less than 10th standard education, and 100% women, they are non-working. Total income, it was majority of families, they have less than 10,000, and majority of women, they belong to Hindu family. And in like multi-gravida, there is 2 mother, they have 2nd trimester, 98 mother, they had 3rd trimester. So when I'm doing a comparison between the multi-gravida mother, so first I'll just see multi-gravida frequency and distribution of their level of hemoglobin. So categorize mild, moderate, severe. So 15 mother in multi-gravida mother, they comes under mild category. 84 mother, they comes under moderate category, and 1 in severe category. Then I have done the comparison between multi-gravida percentage of mother who fall in which category. So in mild category, I have primary gravida mother, that is 27%, and 15% multi-gravida. Moderate case of anemia, I have found 71% in primary gravida, and 84 in multi-gravida. And severe case, 2 was found in primary gravida and multi-gravida. Now, discussion, I have taken a study of Mulugeta, Melko, which was done in 2014. So according to the study, prevalence and predictor of the maternal anemia during pregnancy is Hunar. And the aim of the study was to assess the prevalence and predictor of maternal anemia. A cross-sectional study was conducted by March 2012, and in which he has taken 302 pregnant women. He has taken who were attending and hospital, and the base questionnaire was used. Clinical history laboratory examination was done for HB investigation. Then bivariant, multivariant logistic regression was used to identify the predictor. The prevalence of anemia was 16.6%. Majority were type mild and morphological non-morpholytic anemia. Low income, large family size, hookworm infestation, HIV infection were associated with anemia. So these infection, which was also, these are the factor which was found the mother who having anemia. Now, implication of my study, nursing practice, multi-gravida mother have frequent pregnancies with less spacing in between 2 birth, and also many of them belong to low socioeconomic group. So basically, if mother, they have 2 pregnancies and they have less than 2 years of space, so they're prone to have anemic condition. Because of this, they are more prone to have iron deficiency. Hence, nurses can give community health education or health services in many areas where antenatal, multi-gravida, primary gravida decide. Timely intervention by a community health nurse may reduce the suffering and make feel comfortable. In nursing education, nurses can provide service to the primary gravida, multi-gravida in hospital setting as well as in community setting, and they should be sensitive and they should know about need or priorities of primary gravida and multi-gravida mother. The nurse administrator may post more students, nurses in such community where antenatal mother reside, because health education sessions are equally important and useful for take care of the antenatal mother. Research in such community setting priorities may need of primary gravida, multi-gravida mother, and help to intervene properly and efficiently. So by these research, we can make it out what all factors are there, which are the reason for the anemia in multi-gravida mother as well as in primary gravida mother. More researches can be done in community setting with regard to the age and causes. Studies should be done which into consideration, so we can take all these factors. We can see what all factors are there which are associated with the anemia. So that can be age, education, working status, income, religion, trimester pregnancy. So these nursing research can be done on that topic. Recommendation: replication of the same study in more antenatal mother may help draw conclusion that more definite and be organized to a large population. The study can be replicated in community setting. So that is a recommendation. And evaluative study may be conducted to find out the effect on health teaching program on balanced diet or prevention of anemia on primary gravida mother and multi-gravida mother. So these are the references. Thank you.
Thank you so much. Do we have any questions from our chair? Dr. Chair? Right, seems none. Let's go ahead and proceed. Next is an oral presentation by Soya Katil from Baby Memorial College of Nursing, India. The topic is about the effect of holistic nursing intervention on maternal satisfaction about labor. Soya?
Yes, ma'am.
Go ahead and share your screen.
Shall I start?
Yeah, go ahead.
Oh, okay. Good afternoon to all. Actually, I feel privileged to be the part of Third International Conference on Nursing, Science and Healthcare. I'm thankful to the Society for Nursing Practice for accepting my topic for presentation in this virtual platform. Okay. So the topic of my study is effect of holistic nursing interventions on maternal satisfaction about labor among women receiving obstetric care. Pregnancy and labor is a coupled experience which is inseparable and invincible phase of life of every woman. Every woman expects it to be a memorable bliss rather than a horror dream. As far as this memorable bliss is concerned, supportive care to the women in labor and childbirth have been connected for all of recorded history. Relevance and importance of the study: holistic nursing care considers the psychological, environmental, spiritual needs of patient as well as the physical aspect so that people are treated as whole human beings. Since nurses play the pivotal role in this activity, their knowledge and practice in holistic nursing care and the interprofessional teamwork require much emphasis. Kerala is one of the major regions in India where low birth rate coupled with comparatively higher levels of healthcare delivery system prevails. However, the caregiving system remains as just mechanistic, but not in the holistic way as every woman likes. So defining the problem, a study to assess the effect of holistic nursing interventions on maternal satisfaction about labor among women receiving obstetric care from a selected hospital in Kerala. Objectives: identify the maternal satisfaction about labor among women receiving obstetric care, evaluate the effect of holistic nursing intervention on the satisfaction about labor among women receiving obstetric care, identify the association between satisfaction of women about labor with selected variables. Operational definition: holistic nursing intervention. It includes a group of systematically planned activities to strengthen the care rendered during intrapartum period to ensure the provision of quality intrapartum care. It consists of preparation of nurses to render holistic nursing intervention, preparation of women to undergo labor process, and the measures to manage pain during labor. Maternal satisfaction is the expression of feeling of satisfaction experienced by women in labor when she received intrapartum care during labor and was measured by maternal satisfaction questionnaire on the first postnatal day. Hypothesis: there is significant difference between comparison group and intervention group in maternal satisfaction about labor, and there is significant association between satisfaction of women about labor and selected variables. Design: quantitative, quasi-experimental, post-test only comparison group design, study setting, pre-labor room, labor room, and postnatal wards of Baby Memorial Hospital. And this institution is a 600-bedded multi-speciality hospital with modern diagnostic and treatment facilities with 8 to 10 deliveries per day. Study population: women with normal vaginal delivery, and inclusion criteria: women who had normal vaginal delivery in the first 12 hours of postnatal period, women who were willing to participate in the study and who could read and write Malayalam or English. Exclusion: women who had complicated labor. Sampling: 160 subjects with normal vaginal delivery, 80 each in comparison and intervention group. Sampling technique: simple random sampling of days of 2 months for both comparison and intervention group. Data collection tools: socio-personal data sheet and patient satisfaction with nursing care quality questionnaire. It's a standardized tool. Reliability calculated with Cronbach's alpha, that is value was 0.702. Data collection process: study conducted at Baby Memorial Hospital, Kerala. After getting formal permission from management and ethical clearance from hospital IEC, study conducted from 15/1/2020 to 31/1/2021. And there was 2 group, intervention and comparison group. Initially, the satisfaction of comparison group were assessed. It took 2 months period. And then the holistic nursing intervention introduced or implemented in the labor room. It included equipping the staff nurse with a holistic nursing intervention, providing self-learning instructional booklet to all mothers admitted to labor, and audio analgesia in the labor room. After that, it took about 3 months. After that, intervention group, same way, satisfaction was assessed, and it also took 2 months period. Analysis: socio-personal data, the frequency and percentage distribution. Age: the highest percentage, that is 45.2% of subjects in the comparison group falls in the age group of 23 to 26 years. And in the intervention group, the highest percentage was 36.3% in the it was in the age group of 27 to 30 years. And about the family, more than half of of subjects in both comparison and interventional group, that is 56% and 63.7% respectively, belong to nuclear family. Then the number of deliveries: highest percentage of subjects in comparison and intervention group were primipara, that is 41.7% and 40% respectively, followed by 2 deliveries, 36.9 and 35% respectively. Then the previous admission to the same hospital, more than half of the subjects in comparison and intervention group had previous admission to the present hospital, 51.2% and 56.5% respectively. And the reason for selecting the hospital for delivery: highest percentage of subjects, that is 39.8% in the comparison group, revealed that they selected the present hospital because it was near to their home. And in the intervention group, more than half of the subject, that is 53.8%, revealed that they selected the present hospital for because of good reputation. Then the distribution of maternal satisfaction score of women undergone labor. In the comparison group, majority had good satisfaction score, that is 64.3%. Only 13.1% had excellent satisfaction score. Whereas in the intervention group, 100% of the sample had excellent satisfaction score. The range, mean, standard deviation, median, and 95% confidence interval of maternal satisfaction score. Mean satisfaction score was higher among subjects in the intervention group, that is 112.39 with standard deviation 5.04, compared to mean maternal satisfaction score among subjects in the comparison group, that is 73.73 plus or minus standard deviation 11.83. Then the effect of the holistic intervention, significance difference calculated by using independent t-test. The t-value was 26.973 and p-value less than 0.001. So it revealed a significant difference between the comparison and intervention group. The association of maternal satisfaction score with the comparison group is selected variable in the comparison group. So the data in the table revealed that there was no association between maternal satisfaction score among subjects in the comparison group and selected variable. But in the interventional group, there are two variables that are type of family and number of deliveries. That is chi-square value 6.537, p-value less than 0.010, and chi-square value 10.288, and p-value less than 0.05. It has got a significant association. The conclusion of the study is that holistic nursing intervention ensures better satisfaction among women in labor by improving the quality of services. Holistic nursing intervention might influence maternal and fetal outcome. Thank you.
Thank you so much for that presentation. Do we have any questions from our chair? All right, Team Sun, let's go ahead and invite again Babita.
Yes, ma'am.
Hi, yes, are you ready? I can hear you now.
I'm ready.
All right. Yep, go ahead, please, and share your screen.
Yes, ma'am. Is it visible, ma'am?
Yeah, it is. Go ahead.
Okay, thank you, ma'am. Good morning. The title of my study is Prevalence of Postpartum Depressive Symptoms Among Mothers. Becoming a mother is the utmost ambition of almost every woman. It is a joyful moment for everyone involved when a woman gives birth to a baby. The days and weeks after childbirth are crucial for the health and survival of the mothers. About 50 to 85% of mothers experience some sort of emotional fluctuations in postpartum. Postpartum depression is a major type of mental illness experienced by mothers. Worldwide, around 13% of women who have just given birth experience postpartum depression. In developing countries, this is even higher, that is 20% after birth. In severe cases, mothers may even commit suicide. The affected mothers cannot function properly. As a result, the children's growth and development may be negatively affected as well. So early screening would be useful to identify the symptoms of postpartum depression before it transfers to full-fledged depression. A study on prevalence and risk factors of postpartum depressive symptoms would be helpful to know the magnitude and the contributing factors, and helpful for planning interventional strategies in pregnancy period to prevent postpartum depressive symptoms, to identify the mothers at risk, and also to provide timely support and treatment. Coming to the statement of the problem, a study to identify prevalence of postpartum depressive symptoms among mothers attending postpartum unit, Institute of Maternal and Child Health, Kozhikode. The objectives of the study were determine the prevalence of postpartum depressive symptoms among mothers attending postpartum unit, identify the risk factors of postpartum depressive symptoms, and identify the correlation between postpartum depressive symptoms and risk factors. Hypothesis: there is a significant correlation between postpartum depressive symptoms and risk factors of postpartum depressive symptoms. The conceptual framework of the study is based on Ernst and Weidenbach's prescriptive theory of nursing. Coming to the methodology, the research approach used in the present study was quantitative approach. A non-experimental, descriptive, explorative survey design was used. The setting of the study was postpartum unit, Institute of Maternal and Child Health, Kozhikode. The population of the study was postpartum mothers, and sample consists of postpartum mothers attending postpartum unit for their first hospital visit, means 6 weeks after delivery, at IMCH Kozhikode. The sample size was 400. It is calculated based on the formula 4PQ by D square, where P is taken from the previous research findings. Sampling technique consists is consecutive sampling technique, and inclusion criteria is mothers willing to participate and give consent for the study, able to read and write English or Malayalam. The exclusion criteria of the study was mothers with mental illness and on treatment. Coming to the data collection tools, there were 4 tools used in the present study, and the technique used was self-reporting. The first tool was a semi-structured interview schedule, which consists of 2 sections. Section A, social personal data, and Section B, risk factors of postpartum depressive symptoms. Total 41 items were present in that tool. The second tool was life events inventory. It was a checklist, consists of yes or no, and it consists of the life events experienced by mother in the past 1 year, and total 25 number of items were present, and score ranges from 0 to 25. The third tool was social support measurement scale. It is a rating scale, 4-point rating scale, and it is about the help, support, and concerns received by the woman during postpartum and pregnancy period from her husband, from mother, mother-in-law, her neighbors, relatives, and health personnel. It consists of 30 items, and score ranges from 0 to 90. And the last tool was Edinburgh Postnatal Depression Scale. A Malayalam version of EPDS was used, and this was used for screening postpartum depressive symptom. A cutoff score of more than or equal to 9 was used for identifying postpartum depressive symptom. It consists of 10 items, and score ranges from 0 to 30. Reliability of the tools were tested by Cronbach's alpha, and it was found that alpha is 0.82 for life events inventory, and alpha 0.95 for social support measurement scale, and alpha 0.85 for EPDS. A pilot study was conducted by taking 40 mothers, and it was identified that the study was feasible and the data collected were amenable to statistical analysis. After that, after getting approval from SRC, Scientific Review Committee, and Institutional Ethics Committee of Government College of Nursing, Kozhikode, and permission from Medical Superintendent of IMCH, Kozhikode, the data were collected from 400 mothers who were attending the first postnatal visit from December 4th, 2018 to 31st December 2018. Investigator met the mothers and introduced herself, and based on the sampling criteria, mothers were selected, explained the purpose, assured the confidentiality, and obtained consent from them. After getting consent, investigator collected data using respective tools. On an average, 15 to 17 participants were taken daily for data collection. Mothers found to have depressive symptoms means they are getting a score of more than or equal to 9 on EPDS were referred to perinatal mental health clinic at IMHANS. IMHANS means Institute of Mental Health and Neurological Science, Kozhikode, for further management. Coming to the analysis of the data collected were tabulated, organized, and analyzed with the help of SPSS package version 18. Sample characteristics: among 400 participants, 94% of the participants belongs to the age group of 20 to 35 years. 66.3% were from Hindu religion. 45.5% of them were high school educated. 79.2% of them were homemakers. 8.5% of participants belongs to BPL category. 73.5% of them were living in rural area. 86% of participants had arranged marriage, and 77.3% were from joint family. Coming to the prevalence of postpartum depressive symptom, figure 1 shows that 35.3% of participants have postpartum depressive symptoms, and this prevalence rate is supported by the study conducted by Shenoy et al. In 2019 and Patel et al. In 2015. Both studies were conducted in India, and Asad et al. In 2019. The study was conducted at Dhaka, Bangladesh. In all these studies, prevalence were identified as 29.4%, 48.5%, and 39.4% respectively. Coming to the risk factors of postpartum depressive symptoms, the risk factor of postpartum depressive symptoms were identified by logistic regression analysis. First of all, univariate logistic regression analysis was conducted, and after that, the independent variable which is found to be significant in univariate were subjected to multivariate logistic regression analysis, and adjusted odds ratio was identified. Table 1 shows the estimation of risk of postpartum depressive symptoms among participants with regard to social personal variable, and it shows that mothers, the odds of getting postpartum depressive symptom is higher among the participants who had love marriage and who belongs to nuclear family. Then risk of postpartum depressive symptoms among participants with regard to obstetric factors. Table 2 shows that the odds of getting postpartum depressive symptom is more among participants who had unwanted pregnancy, who had history of illness in present pregnancy, who had preterm delivery or intrauterine death delivery, who had history of postpartum complication, and history of infertility. Table 3 shows the risk of postpartum dysphagia symptoms among the mothers with regard to child-related factors. And table 3 shows that the risk of postpartum symptoms is much higher among participants who had a preterm baby, a baby with minor disorders, a baby with congenital anomalies, and the sex of the baby is not as desired by them. And if they are giving bottle and breastfeeding to the baby, and if their elder child is having any health abnormalities. Table 4 shows the risk of postpartum depressive symptoms among participants with regard to spouse-related factors. The odds of getting postpartum depressive symptom is higher among participants whose husband is having health issues like chronic illness and mental illness and have habits of smoking, betel or pan use, habits of alcoholism, and whose husbands are not having stable source of income, and the participants, they are not staying with their spouse. Table 5 shows the risk of postpartum depressive symptoms among participants with regard to family-related and personal factors.
Hello? Can you hear me? Can anyone hear me?
Yes, ma'am.
Okay, I thought I.
Your voice is audible.
Is that her? She's not back? She's not back? Louisa? All right, we'll just going to go back to her later. All right, let's go ahead to our next oral presentation by Koijam Mamata Devi from SGT University, India. The topic is about the evaluate the effectiveness of simulation-based training versus traditional method of teaching on the retention of birthing care knowledge and skills among students. Koijam?
Okay.
Right, you can go ahead and have it in presentation mode, then you may
Okay.
proceed.
Good morning to all. Today, my topic is to evaluate the effectiveness of simulation-based training versus traditional method of teaching on the retention of birthing care knowledge and skill among the students. And my objective is to evaluate the effectiveness of simulation-based training on the retention of birthing care knowledge and skill among the group A. Next objective, that is to evaluate the effectiveness of traditional method of teaching on the retention of birthing care knowledge and skill among the group B. Third objective, to compare the effectiveness of simulation-based training versus traditional method of teaching on the retention of birthing care knowledge and skill among the group 1 and group B. And next, to find the association between the simulation-based training on the retention of birthing care knowledge and skill with selected demographic variables. Next objective, to find the association between the traditional method of teaching on the retention of birthing care knowledge and skill with selected variables. Introduction. Practical and academic knowledge need to be highly integrated in nursing, and clinical practice is essential for the expert growth of all the nursing students. The shift from traditional teaching method to student-centered teaching challenges nursing ability to create a learning knowledge that will grow safe and capable graduates. Simulation is growing in popularity in nursing education, augmenting learning, teaching patient safety, enhancing clinical practice, teaching the second and third stage of labor, that is burden care, and teaching the clinical judgment skill. Simulation offers students low-risk opportunities to practice the rare and critical events in the controlled environment. Simulations allow the students to practice more than once with or without error. The use of simulation in nursing education is a new culture in a developing country like India. Therefore, the integration of simulation into nursing education required the creation of this culture by enhancing and strengthening the technical capabilities of all the students and helping them implement these strategies safely. And here's, we can say for the previous studies, some previous studies, Kereko A et al. 2021 has conducted one study that related to simulation. In that conclusion, they have find out that education programs that are carried out by computer-assisted simulation and in accordance with the teaching guide were effective on improvement of knowledge skill or newborn first evaluation in the delivery room. And another, Siriniko et al. 2020, simulation are among the most effective means to facilitate learning of complex skill across domains, and different scaffolding type can facilitate the simulation-based learning during the different phase of the development of knowledge and skill. And another study, that is Mohan S. et al. 2019, simulation-based training in medical courses is effective in enhancing the communication skill, self-efficacy, and clinical competence. Multiple patient simulation as a teaching learning strategies in the nursing curriculum are highly effective. And one more study, that is David M. et al. 2018, education increased the midwives' simulated performance in preeclampsia and eclampsia. The performance of the management of preeclampsia and eclampsia in the simulation groups is more than that of the blinded and lecture groups. So we can use a simulation education, which is a self-centered method. In my research methodology, research design I've used is the post-test comparative research design research setting that I have conducted in SGT University of Gurugram, NCR, and College of RR College of Nursing, Gurugram, NCR. And samples is the BSc Nursing 4th year students. And eligibility criteria for sample selection, that is students of BSc Nursing 4th years of SGT University, Gurugram, and RR College of Nursing, and students who are available at the time of data collection, and students are willing to participate in this study. And students of BSc Nursing 4th years who have to write supplementary examination of previous years are excluded in this study. Tools of data collections here divided into three sections, section A, B, and C. Section A here is a selected demographic variables like age, gender, previous burden care, previous obstetric in simulation training, normal vaginal delivery performed in labor room independently, and interest in midwifery. And section B, that prepared a structured knowledge questionnaire, is the MCQ, consists of 30 items. And section C is assessing the OSCE checklist is there for the retention of burden care. And here's reliabilities they're using for the calculation coefficient, correlation, and iterator, and it was found 0.77 and 0.8. And ethical considerations are taken for the ethical approval from us obtained from Departmental Research Committee and Ethical Committee concerns from the head of different selected hospital, that is in SGT as well as the RR. Consent was taken from the students regarding their willingness to participate in the study, and assurance of confidentiality was given. Analysis here we have divided into 5 sections. Section 1 is related to frequency and percentage distribution of sample characteristic, and sections 2, that is distributions of post-test knowledge score and skill score of simulation-based training, that is group 1, and section 3, percentage distribution of post-test knowledge score and skill score of traditional method of teaching, and section 4 is the comparisons of the both group A and B, and section 5, that is association between the post-test knowledge score and skill score simulation-based training group 1 and group 2 with selected variables. Here is the distribution of students according to their demographic variables. In the Figure 1, here I'm showing the bar diagram showing the percentage distribution of sample characteristic both group A and group B. In the group A, mostly age is belongs to 21 to 22 years, as well as in the group B also belongs to 21 to 22 years. In the gender, in the A group, that is 31 students are belongs to female and 7 students are in male. But in the group B, all the students are belongs to female. And regarding the previous training with an obstetric emergency in group B, no one student is having the previous knowledge of obstetric simulation, but in the group A is having for 31 students are having the knowledge and 38 students are having knowledge. And also regarding the delivery perform in the labor room independently, that is in the group B is the 37 persons are not performed, but in the group A 30 students are performed and 8 students are not performed. And also in the interesting of the midwifery that we can consider as the 9 students, 6 students are having the 4 to 7 delivery and none of the students are performing 32. And also for that interesting, we can say is that how much interest do you in midwifery, that is 18 is very much interest in the A group and 19 is average interest and 1 is not interested. But in the group B, 22 is the most interest and 14 is the average and 2 is in the not interested. And here's in the percentage distribution of group post-test knowledge score of simulation-based training group A and group B regarding the retention of wording care. Here's we are showing for the both group A and group B. The group A, we are having for the 79 students are having for the average knowledge, 13 persons are having poor knowledge, and 8 students are having for good knowledge. And under that, in the group B, 55 persons are having for the average and 24 persons having poor and 8 persons is having good. And next is the we consider as the percentage distribution of post-test skill score of simulation-based training group A and B regarding retention of burden care. Here's I'm showing the further figures in the pie chart. In the group A, 37 persons are having for the average and 63 persons having the good skill. And in the group B, 79 persons having the average and also having for the poor in 21%. In the table here, one showing the mean post-test knowledge score of group A and group B regarding retention of burden care. So here in the post-test, in A group is having for the 38 and B is having the 39 and mean score is 17.87 plus minus 1.90. And in the group B, 23.05 and 2.95 in the mean and standard deviation. And table 2, mean post-test skill of group A and group B regarding retention of burden care. Here's in the mean and standard deviation for the group A, that is 37.23 plus minus 1.55, and also for in the group B, that is 29.323 plus minus 2.16. And here's is a comparison of post-test knowledge score of group A and group B regarding retention of burden care. And also is comparing for the group A and 1 is effective and is calculated by T value is 31.08 and is seen by the P value is effective 0.001. And also as well as in the post-test skill score also same is higher as and also is significant with the T value is 33.23 and is P value 0.0001 is significant at 0.05 level of significant. And also here's I'm showing the association between the post-test knowledge score of regarding retention of burden care among the group A with selected demographic variables. Here's is effective in the previous training with obstetric emergency. Here's average is 18 and 20 is the group in the experimental in the A group A that is in the average group, and this is the yes and no. And also here's is the association between the post-test skill score regarding retention of burden care among the group A with selected demographic variables is, and also the previous burden care, as well as the how normal deliveries performed in labor room independently this is association with at the chi-square 0.00 level of significance. And also here's in the discussion, finding of the present studies reveal that the effect of simulation-based training on retention of burden care knowledge among the students in group A with selected demographic variables such as previous training with obstructive simulation was found to be statistically significant. These findings are consistent with the finding of the study conducted as of D, where it was found that students in the simulation community had higher significant score than the control group. And also effect of simulation-based training on the retention of burden care skill among the students in group B with selected demographic variables such as age, gender, previous training with an obstetric simulation of a vaginal delivery performed in labor room independently was found to be significant. However, this finding is consistent with the study conducted by Antonelli PM.R. et al., where it was concluded that the same group shows the better performance, all the domains with a better comprehension of the mechanism of childbirth, managing and assistance of labor and delivery. In the conclusion, the study concluded that there was a significant difference in knowledge score and skill score of Group A and Group B regarding retention of burden care. Group A has more knowledge and skill regarding retention of burden care. That's why nursing students should be trained by giving simulation-based training before their actual clinical exposure. Simulation-based training can be used for educating nursing students, paramedical students to equip them with necessary knowledge and skills so that they can provide a good quality of care to the patient with confidence. This is the reference I have referred it. Thank you.
Thank you so much. Do we have any questions from our chair? All right, it seems none. Let's go ahead and proceed to our next presenter. Oral presentation by KM Sunam from SGT University. The topic is about a quasi-experimental study to evaluate the effectiveness of lactational counseling on breastfeeding behavior and breastfeeding problem among preemie postnatal mothers admitted in maternal child health ward at selected hospital of Gurugram, NCR. KM?
Yes, good morning, ma'am. I would like to thanks to all the organizer committee who give this great opportunity to present my topic. So here I share my screen.
Go ahead.
It's visible, ma'am?
Yes, it is. Please proceed.
Okay. And thank you. So my topic is a quasi-experimental study to evaluate the effectiveness and breastfeeding problem among primary postnatal mother admitted in maternal and child health ward at selected hospital of Gurugram, NCR. So the breast milk is the healthiest for the woman for a newborn. For a child will require later in life. So pregnancy is one of the most transformative experience a woman can have. Feeding counseling can assist women in gaining confidence while also recognizing their unique circumstances and avoid feeding concern and care behavior that interfere with effective breastfeeding, such as providing babies and young children with unneeded drinks, milk, and breast milk replacement. So, need of these studies, professional counseling services can ensure that women and family get the support as well as the fact, guidance, and comfort they need to properly nurture their kids. So feeding counseling can assist mother in gaining confidence while also recognize their unique circumstances and preferences. The counsel can make women overcome obstacles and avoid feeding, concern and care behavior that interferes with the effective breastfeeding, such as providing babies and young children with unneeded drinks, milk, and breast milk replacement. So breast milk is one of the most potent techniques for enhancing infant survival and well-being. It should be commenced within the first hour after birth, within maintenance for 6 months entirely, then continue for another 2 years or longer with the provision of safe and suitable supplementary meals. So it will help to improving worldwide breastfeeding rate, has the potential to save the lives of 82,000 children below the age of the 5 annually, with the majority 87% under the age of 6 months. So as a result, the study goal is to teach postpartum mother understanding of nursing practice. Breastfeeding problem also will help them to promote breastfeeding and prevent complications and to reduce the infant mortality rate. So this problem can be prevented by giving counsel and by providing techniques of breastfeeding to the primary postnatal mother. So the objective of this is to first one is to evaluate the effectiveness of lactational counts on breastfeeding behavior among primary postnatal mothers by comparing the finding of interventional and control group. And second one is to evaluate the effectiveness of lactational counseling on breastfeeding problem among primary postnatal mothers by comparing the finding of interventional and control group. Third one is to find out the association between the post-interventional breastfeeding behavior score of primary postnatal mother and selected demographic variables, and to find out the association between post-interventional breastfeeding problem score of primary postnatal mother and selected demographic variables. And the hypothesis for these studies for H1 is there will be significant improvement in mean post-interventional breastfeeding behavior score of primary postnatal mother in experimental group after administration of the lactational counseling and control group without administration of the lactational counseling, as measured by the latch scale that I have used at the 0.05 level of significance. And H naught is there will be no significant improvement in the mean post-interventional breastfeeding behavior score of the primary postnatal mother in experimental after administration of the lactational counseling and control. And H2 is there will be significant decrease in the mean post-interventional breastfeeding score of primary postnatal mother in experimental group after administration of the lactational counseling by the breastfeeding problem assessment scale at 0.05 level of significance. And H naught is there will be no significant decrease. And S3 is there will be significant association between post-interventional breastfeeding behavior score of primary postnatal mother and their selected demographic variables. And H naught is there will be no significant association. And H4 is there will be significant association between post-interventional breastfeeding problem score of primary postnatal mother and their selected demographic variable. And H naught is there will be no significant association between post-interventional selected demographic variable. So the research methodology that I have used for this study is the research approach is quantitative research approach, and design is after only non-equivalent control group design, only post-test design, quasi-experimental to evaluate the effectiveness of lactational counseling. The schematic representation of this study was like, I have divided in a two group, interventional group and control group. In our interventional group, X1 is denote like administrating lactational counseling among primary mother, and O is denoting for the assessment of breastfeeding behavior and breastfeeding problem among primary mother. Like on day 1, I have in the interventional group, I have given the lactation session on breastfeeding behavior and problem and its management among primary postnatal mother. On in the control group, I have not given the intervention. And on the of the structure interview schedule for post-test to evaluate the breastfeeding behavior and the same on the second day 2 and day 3 also in the interventional and control group. So variable counseling and independent variable for the present studies to for the breastfeeding behavior and breastfeeding problem. And demographic variable I have selected for the studies: age, education, religion, occupation, type of family, monthly income of the family, place of residence, and previous knowledge and their sources regarding the breastfeeding. Setting of the study: this study was conducted at SGT Hospital, Budera Road, and Signature Hospital, Gurugram, Haryana. And sample was selected 20 sample for the pilot study, and 60 sample primary postnatal mother I have taken for the main study, 30 in the interventional group and 30 in the control group by purposive sampling technique. Data collection techniques which I have used sample for the sample characteristics to collect section 1 to collect the demographic characteristics, and breastfeeding behavior tool latch skill that I have used to evaluate the breastfeeding behavior among primary postnatal mother in both intervention and control group by interview to evaluate the breastfeeding problem among primary postnatal mother in the both group by interview technique. And next one is the I have interpreted the data in the 7 section. So in the section 1, description of the demographic characteristics. In section 2, I have interpreted the finding related to distribution of breastfeeding behavior score among study sample in interventional group and control group. In section 3, finding related to distribution of breastfeeding problem score among study sample, distribution of breastfeeding problem score interventional group and control group. And in section 4, findings related to effectiveness of lactational counseling on breastfeeding behavior among primary postnatal mother and interventional and control group. In section 5, finding related to effectiveness of lactational counseling on breastfeeding problem among primary postnatal mother, interventional and control group. In section 6, finding related to the association of breastfeeding behavior after lactational counseling with selected demographic variables. And in section 7, finding related to the association of breastfeeding problem after lactational counseling with selected demographic variables. So in section 1, the section describes the sample characteristics. So this is the bar diagram showing the percentage distribution of primary mother in terms of the age. In experimental interventional group, majority of the primary postnatal mother in the age group of 18 to 22 years of age in the experimental, and same in the control group, 60% of the primary postnatal mother in the age group of 18 to 22, and 23 to 27 years in between this age group. In experimental group, there are 36.6% of the mother, and in control group, there are 30% of mother. In 28 to 32 years of age, there are 10% in expel and 10% in control group. By the same in education, in experimental group, there are 3.3% illiterate mother. In experimental, in control, there are 16%, 16.6 approx. And primary education, majority of the primary mother in experimental are the primary education, 53.3%. In control is 50%. In secondary higher education, 33% in experimental, and control in is 20%. In graduate, 10%, and in control they are 13.3% of mother. Religion, same, majority of the samples, they are 76.6% in the control group which related to the Hindu religion. And in experimental same 60% mothers belongs to the Hindu religion. In control, Muslims are 26.6 and 10% in control and 3.2. In occupation, majority of the postnatal mother are housewife, 16.6%. That is in experimental group. In control group, there are 80%. And type of family, in experimental group, there are 70% mothers belongs to the nuclear family and 30% to the joint family. In experimental group and control group, 56.6% of the mother belongs to the nuclear family and 26.6 belongs to the joint family. Family income, in experimental group, they are in experimental group 13.3% mothers belongs to the family income is 5,000 to 10,000, and in control 36.6%. In between the 10,000 to 15,000 is 43% mothers under this income, and 40% in control group, and above 50,000 income is 43.3% in experimental group and 23% is in control group. Type of community in experimental, 63.3% mothers belongs to this rural community, and in 36.6% in urban community. And in control, 76% mother belongs to the rural and 26.6% belongs to the urban community. In previous knowledge, in experimental group, 20% mother having the previous knowledge, and 80% mother having no previous knowledge, not having previous knowledge. And in control group, 13.3% having the previous knowledge, and 86.6% mother not having any previous knowledge. So this in section 2, distribution of the breastfeeding behaviors. In section 2, distribution of the breastfeeding behavior score in intervention and control group by the latch scale. In experimental group, they are I have divided in adequate and inadequate knowledge. So in experimental group, 76.6% mother having the adequate knowledge on a day 1, and on day 2, 83.3% having the adequate knowledge, and on day 3, 86.6% mother having the adequate knowledge in experimental group, and 23.3% mother having the inadequate knowledge in experimental group on a day 1, and 16.6% mother having the inadequate knowledge on day 2, and day 3, on a day 3, 13.3% mother having the inadequate knowledge. And control group, there are 56.6% mother having the adequate knowledge on a day 1, and 43.3% mother having the inadequate knowledge. On day 2, 63.3% mother having the adequate knowledge, and 36.6% mother having the inadequate knowledge. And on day 3, 63.3% mother having the adequate, and 36.6% mother having the inadequate knowledge. So for the findings related to the effectiveness of lactational counseling on breastfeeding behavior, I have among primary postnatal mother, on day 1 in interventional group, the mean score is 12.26 and plus minus 2.94 standard deviation. In control group, 9.66%, and plus minus 2.27%. On days 2, in interventional group, the 12.93 is the mean, and 2.27 is the standard deviation. And in control group, 9.26 plus minus 1.97. And on day 3, interventional group, it is 13.46 plus minus 2.62. In control group, that are 9.4 plus minus 1.96. So for the significance of the mean difference between the post breastfeeding behavior score, I have used the repeated ANOVA test F value. So on first day, in the interventional group, they are 17.77, and in control group 2.26, and the table value is 3.15. So in the interventional group, at the level of the 0.05 level of significance, it is significant in the control group, and in control group that is not significant. So finding section 5, findings related to the breastfeeding effectiveness of lactational counseling on breastfeeding problem. On day 1, in interventional group, the mean is 2.06 and plus minus 2.44. In control group, 3.3 mean is the and plus minus 2.642. On day 2, in the interventional group, the mean
Over
is
10 minutes.
1.66. Yes, numbers last 2 minutes. Sorry. In control group, 3.5 and in plus minus 2.5. On day 3rd, on intervention group, 1.16 and 1.94. In control group, 3.66 and 2.29. So for the comparison of the post intervention, at the level of the 0.05%, the F value is 14.18 in the intervention group and 2.40 in the control group. So at the 0.05 level, it is significant in the intervention group. So finding related to the association between the behavior and the demographic variables. So I have used the chi-square test. For this association, only in education, that this demographic, that only in the field of education is the chi-square significant at the 0.05 level of significance. And in section 7, findings related to the effectiveness of post-test score on breastfeeding problem. This demonstrates that only in the field of education is chi-square significant at the 0.05 level of significance. So the conclusion is the efficiency of lactational counseling in terms of breastfeeding behavior and problem among primary postnatal mother was investigated in this study. So according to the finding of this study, lactational counseling was effective in improving the breastfeeding behavior and decreasing breastfeeding problem primary postnatal mother in interventional group. Thank you. Thank you, sir.
Thank you so much. Do we have any questions from our chair? Right, seems none. Now let's go ahead and we call Babita.
Yes, ma'am.
Yep, go ahead.
Pardon me, ma'am. I face some network issues. That's why.
No problem. Proceed.
Yeah. I'm starting from the slide at which I face some network issues. Okay. So I was presenting about the risk factors of postpartum depressive symptoms. So the odds of getting postpartum depressive symptoms is higher among participants who had family history of mental illness, who have a history of major physical illness, history of mental illness, and they had unpleasant delivery experience and had forced and stressful experience of postpartum rituals. Table 6 shows estimation of risk of postpartum depressive symptoms among participants with regard to social support and life events. And the table shows that there is a significant risk of postpartum depressive symptoms among participants who have history of adverse life events in the past 1 year. And it also shows that social support is a significant protective factor for postpartum depressive symptoms. Table 7 shows the major risk factors of postpartum depressive symptoms among participants. After adjusting for other variables, it was found that history of infertility, health of child, and life events were the major risk factors of postpartum depressive symptoms, and social support is a protective factor for postpartum depressive symptoms. Coming to the correlation for testing, hypotheses were stated, and it was verified by Carl Pearson correlation coefficient at 0.05 level of significance. And figure 2 shows the correlation between social support and postpartum depressive symptom. And from the figure, it is clear that there is a negative correlation exists between social support and postpartum depressive symptom. Since p-value is less than 0.05, null hypothesis was rejected, and it can be concluded that higher the social support, lesser the chance for postpartum depressive symptom. Figure 3 shows the correlation between life events and postpartum depressive symptom. And it is evident that there is a positive correlation exists between life events and postpartum depressive symptom. Since the p-value is less than 0.05, null hypothesis was rejected, and it can be concluded that the higher number of life events, higher the chance for postpartum depressive symptoms. Coming to the discussion, major risk factors of postpartum depressive symptoms were discussed. So in the present study, it was identified that in obstetric factors, history of infertility is an important risk factor, and this was supported by Burgett et al. Study conducted in Goethe. The same findings was identified in that study. Then child-related factors, it was identified that the health of the newborn child is a significant factor for PPDS, and it was supported by the study conducted by Wubutu et al. In Ethiopia. In that study also, health of newborn child was found to be a significant risk factor for postpartum depressive symptom. And social support, in Vasi et al. Conducted a study in 2019, and they identified that there is a reverse significant association between social support and postpartum depression. And a study conducted by Ginduvano et al. In 2018, and that study predicts that life events are significantly associated with the postpartum depression. Coming to the conclusion, the present study, the prevalence of postpartum depressive symptom was identified as 35.3%. History of infertility, health problems to baby, adverse life events were found to be the major risk factors for postpartum depressive symptom, and social support was found to be a protective factor for postpartum depressive symptom. So early screening of the mothers, especially in third trimester of pregnancy and in postpartum period, using EPDS is highly recommended, and also recommends midwives and healthcare providers, they should be trained and given opportunities to identify the mothers at risk for developing postpartum depression and to undertake preventive strategies and controlling approaches. Based on the findings, it is suggesting to integrate mental health services with the maternal and child health services in the community level, so we can make women's mental health better in the postpartum period. Thank you. Thank you.
Thank you so much. Do we have any questions from our chair? All right, Team Sun, let's go ahead and proceed with our next presenter. An oral presentation by Banapriya Sahu from SGT University, India. The topic is about a quasi-experimental study to assess the impact of skill training program for STP regarding postnatal care of mothers who underwent LSCS on competencies among students in selected nursing institution at NCR, Delhi. Banapriya?
Yes, ma'am. Thank you, ma'am. It's a great pleasure for me to present my study paper in such an international conference platform.
Go ahead and share your screen.
Am I audible, ma'am?
Yes, you are.
Okay. Is my screen visible?
It's coming up. Right? Go ahead. Go ahead, please.
Okay, ma'am, just my study title is quasi-experimental study to assess the impact of skill training program regarding postnatal care of mothers who underwent LSCS on competencies among students in selected nursing institution at NCR, Delhi. My guide is Professor Dr. Akwizam Mamta Devi, ma'am, Professor and HOD of Obstetric and Gynecology Nursing Department from SGT University, and my co-guide Havizam Madhuwala Devi, ma'am, Assistant Professor from SGT University. This is a glimpse of my study. And why I have selected this study is that the health and survival of mothers and children are vital to society's well-being. A cesarean section is a surgical procedure in which the infant is extracted through incisions made in the mother's abdomen. In present scenario, the first growth in rate of cesarean section is an extreme burden for the society. And as accepted by the WHO, the maximum of 15% is set by the WHO for cesarean section rate. And in the data, I'll say that from the source, Health Management and Information System, Ministry of Health and Family Welfare. According to the data, there is a highly increasing of cesarean section deliveries in public institutions, where is 311% rise from 2008-9 to 18-19, whereas in private institution it is more than that, that is 413% from 2008-9 to 2018-19 figure. And cesarean section is a major abdominal surgery and may result in more discomfort, longer recovery, and difficulty returning to normal activity than vaginal delivery. In some nations, the cesarean section technique of delivery has doubled in 15 years, with reaching alarming portions. And as updated by the WHO 28 March as in 2019, the maternal deaths following cesarean section in low and middle income countries are 100 times higher than the high income countries. Due to this gap in source, resource, and skills in provider to manage complication and a need-based scientific training to all healthcare providers, the mortality and morbidity rate is increasing after cesarean section. My hypothesis are H1 is there will be significant difference between pre-test and post-test competency scores of nursing students and postnatal care of mothers who underwent emergency LSS at the level of 0.05%. And my H2 is there will be a statistical significant association between post-test competency score of nursing students with the selected demographic variables at the level of 0.05%. My assumption is the students may have competency about selected postnatal care of mothers who underwent emergency LSS. After receiving this skill training program, which I am providing in this study, in this research, the students may gain some competencies about selected postnatal care of mothers who underwent emergency LSS and may influence their practice. My delimitation of the studies are, study is only open for nursing students 4th year basic BSc nursing course, and the study is restricted to only selected nursing institutes which are situated at NCR Delhi. The study findings cannot be generalized due to the small sample size, and the information will be gathered in the 1 month. Regarding next research about research methodology, my research approach is quantitative approach, and I have used the quasi-experimental with non-equivalent pre-test post-test design. And in I have both groups, study group and control group. Initially, I will take the pre-test from both the groups. Then I will give the intervention only to the study group. After that, I will take the post-test from both the groups. Then my variables of study. First, there is demographic variable. I have included the age, sex, religion, educational qualification, parents, area of residence, and whether they are having any previous knowledge or source of infection. And my independent variable in this study, the skill-based training on selected postnatal care of mothers who underwent emergency LSS in the independent variables. Then dependent variables in this study, the dependent variables are competencies of the nursing students, my participants regarding postnatal care of mothers who underwent emergency LSS. And population are the basic BSc nursing students. Research setting is Faculty of Nursing, SGT University. And though I have two groups, my study group is Faculty of Nursing and my experimental group is RRS School and College of Nursing, which is also situated at Gurgaon, Haryana. My sample is students studying basic BSc nursing in nursing institution at NCR Delhi who fulfill the inclusion criteria. Sample size is total 60 nursing students I have taken, among them 30 experimental and 30 control. And I have used the convenient sampling technique. My inclusion criteria are nursing students who have successfully passed 3rd year basic BSc nursing examination and who are studying 4th year basic BSc nursing course. Exclusive criteria are nursing students who are not continuing the 4th year basic BSc nursing course and they didn't pass 3rd year examination. And also those students who are not willing to participate. And regarding the tool description, I have used 4 tools. First is to collect the demographic characteristics of data. And the second one is procedure checklist. Actually, here I have developed 3 skills, and according to the skills, I have also developed the checklist with the procedures step by step. And my 3 skills are technique of breastfeeding, wound care, and postnatal exercise. Then regarding the postnatal care and 3 skills, I have developed a structured knowledge questionnaire. Then to follow that procedure checklist, I have developed a OSCE, so that through the OSCE, I can take the pre-test and post-test. Pilot study, I have conducted the pilot study at 2 institutions in the Gurgaon. And my reliability are found that for the knowledge, it was 0.85, which is reliable. And for the checklist, I have used the iterator method. And for the above 3 skills are 0.87, 0.81, and 0.88. So hence my tool is reliable. Initially, I have prior formal permission I have taken. After that, the purpose of the study I have explained to all the participants and my study participants. Then consent I have taken from all the participants. After that, I administer the self-care questions and ask it to take the pre-test. Then I have provided the skill training program to each in 3 days. Then post-test I have conducted after 7 days. Then the duration of the total data collection is 4 weeks. Now my analysis and interpretation. Regarding demographic variables, most of the students are from 21 to 22 years of age in both experimental and control. And most of the students are female. And also maximum are from Hindu religion. And regarding parents' education, in secondary education group, maximum students' parents are belonging. And almost it's similar, equal for both rural and urban. And many of are having the previous knowledge. And regarding next, comparison of pre and post-test knowledge level before and after providing skill training program. Pre-test knowledge, you can see in experimental group, in adequate category, there is only 3.3%, whereas in control group, it is 0%. But you can see the comparison here. After providing the skill training program, the experimental group has gained the knowledge from 3.3 to 50%, whereas the control group remain in the same 0 and 0%. And likewise, in average group also, it is showing the changes. And here the experimental group inadequate, those who are in inadequate category before pre-test, they have also the number of inadequate category has reduced. Next, overall pre and post level, skill level. In pre-test, you can see in experimental group, it is 0, whereas after providing skill training program, it gained to 60%. And it's a huge significant for me to conduct the study. Then in control group, it is constantly the figure is same 0%. And now after that, I've used overall the knowledge score. There is a means difference which is very large in experimental group, that is 6.20, whereas in control group only 0.20. So it is showing significant. And the same for skill score. The main difference is 23.83 in experimental, whereas 0.27 only remained at control group. And secondly, association among us post-assessment competency with selected demographic characteristics. In selected demographic characteristics, I have found the statistical significant association with those are having previous knowledge. Other demographic variables, age, sex, religion, parents, education area are not significant. Hence, my S2 has proved here. Then conclusion, the outcome of this present research show that students are fairly capable of providing post-operative care to mothers who LSCS afterwards skill training program. They had good enough knowledge and desirable skill about breastfeeding technique, wound care, postnatal exercise. Overall, the competency level has increased. Skill training program also helps the students to construct and enhance networking, time management, communication abilities, along with developing skill in a selected area. And my nursing implication regarding nursing practice, The findings of the study could be utilized as basis for providing training to students, and students can practice the same regarding their post-operative care after LSS during their clinical posting. Nursing education in nursing curriculum has to focus on enable the students, nursing students to develop skills in identifying risk groups and prevent the complications. Nursing administration, the present study is proposed to help the nurse administrators to strategically plan and meet the training needs of the students in different areas. And nursing research, the effectiveness of the study can be verified by its utility by the students, nurse in the practical field. And my recommendation from the study are the study might be repetitive with a large sample of nurses from different nursing institutions. Further, the STP used in this study can be provide a comprehensive learning experience in all nursing institutes by taking care of all stages of learning transfer before, during, and after the skill training program. The skill training program also can be planned for working staff nurses, and the effectiveness of STP can be found out by the research study. To evaluate the competence connected to the course, a comparative research between degree and diploma holder nursing can be done. Thank you all.
Thank you so much. And do we have any questions from our chair? All right, let's go ahead and proceed to an oral presentation by Shalu from SGT University, India. Oops. A study to access the effectiveness of planned audio teaching program on menstrual hygiene in terms of knowledge, altitude, and practice among visually challenged females of reproductive age group in selected area of NCR. Oh, okay.
Hello, good afternoon, ma'am. Am I audible to you?
Yes, you are.
Thank you, ma'am.
Right, proceed, please.
Is it visible, ma'am? My screen is visible.
Yes, go ahead, please. Madam, please proceed.
Yeah, sure, ma'am. A very good afternoon, ma'am. Myself, Shalu. I'm assistant professor from Faculty of Nursing, SGT University. So today I'm going to present my topic, a study to assess the effectiveness of planned audio teaching program on the menstrual hygiene in terms of knowledge, attitude, practice among the visually challenged females of reproductive age group in selected areas of NCR. So my objectives of the study was to assess the pre-test knowledge, practice, attitude score among the menstrual hygiene among visually challenged females of reproductive age group. So second objective was to evaluate the effectiveness of audio teaching program to visually challenged females of reproductive age group in selected area of NCR. Third objective was to assess the post-test knowledge, practice, attitude score regarding menstrual hygiene among visually challenged females of reproductive age group in selected areas of NCR. Fourth is to find out the association of knowledge, attitude, and practice pre-test and post-test score regarding menstrual hygiene with selected demographic variables. So these all are my objectives of the study. Next, introduction. I have chosen this topic because in India, it is the second most popular country in the world and home to over 20% of the world's blind population are available in the India. So blindness is a serious public health problem globally. 80% of this problem either preventable or treatable, and this occur in the developing nations of the world. So as the India is a developing country, so we are having a much more population of the blind, visually challenged females in India. The World Health Organization estimates for every 5 seconds someone goes blind today or daily basis. WHO estimated that there are 180 million people worldwide visually disabled. Blindness and vision impairment remains major public health problems in the India. There is a difficulty arise when there is interaction with visually impaired females and talk to about them reproductive health and menstrual hygiene and communicate the right information regarding the menstrual hygiene maintenance. Sometimes if it is there any misinterpretation in the communication and they understand the information not accurately, which leads to these females are following the wrong practices. And to fulfill this gap, the information to those challenged girls are provided with the help of audio-visual aids, which help them to understand the easily and helpful for them in future. There is some glimpse of the previous study. It is a review of literature. So first review of literature is done by Ms. Amrita Paudel at 2021 in 2020-21. This study was the mean age of 17 years female we have taken and 12 years of female. So in that 66% females falls under blind category, and these are having a low, 34% having a low vision and 52.9% and 52.9% knew about menstruation before menarche through their mothers, who was the main source of information. Overall, 48.8% had a good knowledge and 52.1% had a satisfactory practice knowledge, was significantly among the visually challenged females among the India. Second review of literature was Tuga Dunbar in 2020. The study sample included 187 visually impaired women. And in this study, it is concluded that the visually impaired women had difficulty in managing their menstrual periods independently. Their menstrual hygiene practices were not desirable. Almost half of them received support in menstrual hygiene management, and most of them used some indicators to determine the start and end of their menstrual periods. Third review of literature, the study was done by Mrs. Prema in 2020. Here, the sample size was 30 visually impaired adolescent girls will be taken. With the help of semi-structured questionnaire tool, they will assess the knowledge regarding menstrual hygiene, and through the checklist, they will assess the self-reported practice. So in that, the study result shows that the 3.33% had a good knowledge and 93.34% visually impaired adolescent girls had average knowledge, and 3.33% women are having a poor knowledge regarding menstrual hygiene. In post-test, all visually impaired adolescents were 100% having a good knowledge. The majority of 29 of the visually impaired adolescent girls indicate good self-reported practice, where the 1% woman was having average self-reported practice regarding menstrual hygiene. So there was a highly significant difference seen in the self-reported practice according to the mother's education at the level of, at the p-value of less than 0.05. These are the review of literature of the study. So methodology of the study is research methodology. Research design was one group pre-test post-test design we have adopted for the study. Second, research setting. We have conducted the study at the selected blind schools in NCR. Sample and sample size. Sample and sample size are 60 visually challenged females of the reproductive age group we have received. Sampling technique was convenient sampling technique. Inclusion criteria we have selected the visually challenged females of reproductive age group who are studying in the selected blind centers of NCR. The visually challenged females of reproductive age who attain menarche. the visually challenged females of reproductive age who are willing to participate in the study. So these all are the inclusion criteria of our study. Next is tool for data collection. The tool was organized into the 4 sections for the data collection. The first section, in which it deals with the selected demographic variables, in which we consist of 14 selected demographic variables like age, gender, religion, occupation, education, etc. Second is section B. Section B is self-structured questionnaire is used to assess the knowledge regarding menstrual hygiene among visually challenged females of reproductive age group. They consist of 3 areas, which contains 21 items. They are questions related to anatomy, physiology of reproductive system organs. 4 items are related to that. Questions related to menstruation are 6 items are included in that. And questions for menstrual hygiene, total 11 questions we have included on related to menstrual hygiene question. So total 21 questions we have included in section 2. Section 3, we have included the Likert scale. It is used to assess the attitude of visually challenged females of reproductive age group regarding menstrual hygiene. And this scale consists 21 statements for attitude. Fourth section was, it contains non-observational checklist for assessing the practice. The checklist contains 21 statements. Each statement have response in yes or no. For yes, the 1 scoring is given, and for no, the 0 scoring is given to assess the practice. So these are the 4 sections we have prepared for data collection. Then analysis. In analysis, our first is distribution of subject according to socio-demographic variable, in which first is age. So we are having a percentage 11 to 19 years is 30%, 20 to 29 years 50%, 30 to 39 years is 16%, 40 to 45 years is 30%. Second is education, in which we have considered illiterate, 3.30 is illiterate, primary, 16.70 is primary, high school is 16.70 high school, intermediate 31.70% intermediate, graduation 25% graduation, post-graduation 6.60 post-graduation. Next is religion. Religion is Hindu, Muslim, Christian and Sikh. In Hindu, 90% we are having socio-demographic variable samples are 90%, Muslims are 10%, and Christians and Sikh, we are not able to found any Christian and Sikh in our convenient sampling sample. So type of family, nuclear family and joint family. Some of our samples are living in their family also. So we have taken the samples as per our convenience from the families also. So nuclear families are 66.70% and joint families are the 33.30%. Then marital status. In marital status, we are having a 3 category: married, unmarried and widow. So in married, 40% females are married. Unmarried, 60% are unmarried, and widows, there is no widow is found in our samples. Distribution of monthly family income demographic variable is less than 10,000 is 81.70%, 10,000 to 15,000 18.30%, and more than 15 to 20,000 or in between 15 to 20,000 we don't find any sample. Those are having an income in between that. Then area of residence, urban is 43.30%, rural is 56.70%. Next is previous knowledge regarding menstruation. So 86.67% of females are having previous knowledge regarding menstruation by the different sources, and 13.33 females are not having any previous knowledge regarding menstruation. Second is regular menstruation. So in that, the 85% women are having regular menstruations and 15% females are not having their regular menstruations. Next is source of information. So if there are some of the females are having a previous knowledge regarding menstruation, so from which source they have getting the information, there is a different type of sources. So parent, through parent, 28.34% females are having a source of information. Teachers, 25%. Friends, 20% they are getting the source from friends. Elders, 13.33% they are getting from mass media, TV, radio. Nobody is getting this because from they are not listening the other, like they are not able to see the video, TVs and all those things. So they are responding as the 0 because they are visually impaired. So they are responding, we are not watching the TVs and all. Then none, 13.33%. Then duration of menstrual cycle. So women's below 28 days cycle, 30% of women are having a below 28 days of cycle. 48.40% are having a 28 to 30 days regular cycle, and above 30 days cycle, 20.60% females are having a above 30 days menstrual cycle. Next is duration of menstrual cycle. There is a less than 3 days, 26.70%, 3 to 5 days, 56.70%, and 6 to 7 days, 13.30% of duration of menstrual flow in this percent of women we are having. Next is pain during menstruation. So 58.30% samples are having a pain during menstruation, and 41.70% samples are not having pain during the menstruation. Next is discomfort during menstruation. So it is equal 50% females are feeling discomfort during menstruation and 50% females are not feeling discomfort during menstruation. So these all are the distribution of subjects according to the socio-demographic variables. Next, the second section, we have assessed the level of pre-test knowledge score and post-test knowledge score. So here is the graph, which is the red color is showing the pre-test knowledge score of the samples and green color is showing the post-test knowledge of samples. So when we are conducting the pre-test knowledge, it was a very poor knowledge of among the samples. Then average poor knowledge is 30% among the samples, and average knowledge is 70% in pre-test, and good knowledge is only related to 10% in the pre-test score. Then we have giving the intervention, we have giving the audio teaching aid, and we have to implement that audio tool to the samples. After that, they are listening to the audio and they will gaining the knowledge. After that, we are conducting the again post-test, so their knowledge scores will be increased. It will poor knowledge score, it will get reduced. The previously it is 30%, it will get reduced to the around 5 to 10%. In average knowledge also it will get reduced. Previously it is very high, 70% of samples are having average knowledge. Then after post-test, this will get reduced to the 35 to 40%. Then good knowledge, they will be increasing their knowledge. So previously they are having a very little bit good knowledge. So after intervention, their knowledge will be enhanced. So it will be little bit 65 to 75% of samples we are having a good knowledge after implementing the audio teaching aid. Next is distribution and comparison of the level of pre and post test practice score. So we have assessing the non-observational practice through the checklist. So this is the score. The blue is showing the pre-test practice score and orange is showing the post-test practice score. So previously they are having a more poor practices before intervention, before we are giving the audio teaching aid, and later on it will reducing. Previously it was a 25 to 35% of poor practice, average practice by 75 to 80%, and good practices very less in pre-test. It is around 5 to 10%. Then after implementation of audio teaching tool, the practices will be improved. Poor practice will be reduced by the 25 to 30% to the 5 to 10%. Average practice also reduced, and it will automatically good practices will be improved. So it is related 75 to 80% good practices will be improved after intervention. Next is there is the distribution and comparison of level of pre-test and post-test attitude score. So we are also assessing the attitude among the visually challenged women related to menstrual hygiene. So there we are assessing there are two categories, negative attitude and positive attitude. So in pre-test is showing the green color and post-test is showing by the blue color. So previously in pre-test, they are having a high negative attitude toward the menstrual hygiene. They are not performing, or they are not feeling like they are not able to perform proper hygiene because they are visually impaired. So they are having a little bit higher negative attitude before the intervention. After intervention, their positive attitude will be increased. their negative attitude will be automatically reduced and their positive attitude will be increased by the more than 70%. So they will be more confident whether they will be maintaining the good hygiene practices after the intervention. Next is section 3, the comparison of mean, pre-test, post-test scores of knowledge, practice, and attitude. So we are comparing all the knowledge, practice, and attitude score to identify there is a comparison. So our t-test value is showing the comparison in between the knowledge, practice, and attitude at the significance level of 0.05%. So our t value is 0.001. It is showing that there is a significant comparison in between all three practices. The knowledge, practice, and attitude is correlated with each other. Next is, in third section, we are showing the level of knowledge among the practice, attitude, we are showing the association between the knowledge, practice, attitude with the demographic variable with the help of ANOVA test. I'm implementing the analysis of variance. Just wait a minute, I will show you the tables.
Are you done? I mean, the PowerPoint.
Just wait a minute, I will share another sheet, ma'am. Is it visible, ma'am?
Yes, it is. Thank you.
So we have assessing the association between pre-test knowledge score with the demographic variable. So we have found that the education is having an association with the knowledge score. Those who are having education is showing the association with the knowledge score. And other than this, we are having a knowledge of previous menstrual cycle is also having some association with the knowledge score. So those are having a previous knowledge score and those are educated, they are little bit aware about the menstrual hygiene. They are having some knowledge. So they are showing the association with these two demographic variables. Other than this, the regular menstruation is also showing the knowledge association with the knowledge because those women are having a regular menstruation. They are aware about how they will manage the menstruation in comparative to those are not having a regular menstruation. Then menstrual flow, as per the menstrual flow also they are showing the association with the demographic variables with the knowledge score. So this is about the pre-test knowledge score, and in post-test knowledge score, they are showing the association with the selected demographic variables of knowledge of menstruation. Again, the knowledge of menstruation and sources of information. These two demographic variables are showing the association with the selected demographic variables in pre-test and post-test knowledge. Then in pre-test practice score, they will be showing the association with the they are not showing any association with the selected demographic variable in the pre-test knowledge practice score. Then in post-test practice score, they will be not showing any significant correlation in the post-test knowledge practice score also. Then third one is the association with the pre-test attitude score. So in pre-test attitude score, they are also showing with the two selected demographic variables. They are showing the correlation association with the knowledge of menstruation and sources of information again with the attitude. These two demographic variables will showing the correlation with attitude. And in post-test, they are not showing any correlation with any selected demographic variable. So these all are the findings of our study. So in that we are concluded. So in the last, the conclusion of the statement was the female those are visually impaired, they are having a they are not having a previously adequate knowledge regarding the menstrual hygiene. They are having a negative attitude towards because they are not able to maintain their proper hygiene due to their visual impairments. So after giving the interventional, so they are improving their negative attitude into the positive attitude. They will obtain the good knowledge. They will maintain the good practices regarding the menstrual hygiene with the help of audio teaching aid. So it is very best method. We found that it is a very best method for the visually challenged women because they are not able to see anything. So through the audio, we can improve. We can improve their knowledge, practices, and their attitude related to that. So in the last, there's the recommendations of the study. On the basis of these findings, the study can be conducted to prevalence of reproductive tract infections. We can also conduct a study due to improper hygiene, menstrual hygiene. We can also assess the prevalence of reproductive tract infection in visually challenged women. Second, we can do the comparative study among the rural and urban areas of visually challenged females. Third, we can conduct a similar studies in the large sample areas in a large population. And fourth one, we can do the comparative studies can be done in between the different states. For example, in Haryana, Delhi, among the visually challenged.
Over time.
Thank you, ma'am. My presentation is over. Thank you.
Thank you so much. Are there any questions from our chair? And next, let's proceed with an oral presentation by Geetanjali Surwal from SGT, India. The topic is a descriptive study to assess the knowledge regarding cervical cancer and its prevention among female students of first year of SGT University, Gurugam. Hold on, I think I've read it. Oh, yeah, correct. Hello, Gatali, Geetanjali. Surwal. Next, let's go ahead with an oral presentation by Raman Deep from SGT University, India. The topic is about the knowledge, risk perception, and precautionary actions taken by residents regarding COVID-19, an online cross-sectional survey. Ramandeep, hi.
Yes, ma'am. Good afternoon to one and all present here. Myself, Ramandeep, professor from SGT University. So thank you for giving me this chance to present at this platform. And I would also like to congratulate ITM University for collaborating with BioLeaks and doing this wonderful conference. Have you shared the rights to share? Have you shared the rights?
Hold on, let me check. Please, team, please give Dr. Rahman co-host access. Zilla?
Yes, Jojo.
Okay.
Is it
up.
visible?
Thank you.
Yeah.
Yes?
Okay.
Go ahead, please. Thanks, Gisela.
Thank you so much. So knowledge is better than wealth, as you can look after the wealth, but if you have the knowledge, it will look after you. So it is a famous African proverb. I would like to start with this. So while introducing use of disease appropriate health behavior, that is, okay. Yeah. So use of disease appropriate health behavior, which is practiced by general public, it depends on the risk perception of a disease. So higher the risk perception of an infection, it will in general lead to changes in their health practices, and it will incite the act of preventive practices which go about as elements which will control the spread of disease episodes. On the contrary, inordinate dread of disease, it will cause pointless social expenses and pointless stress to the person. The use or upgradation of health behavior practices by the general public, it depends on the risk perception of a disease. High risk perception of an individual, it will lead to more of, I think I have not changed the slide. So considering the past irresistible breakthrough episodes, including severe acute respiratory syndrome, SARS, and H1N1 flu, a few investigations have been performed to survey the connection between the impression of residents about the outbreak and the act of preventive practices, what they are doing. Conversely, just a couple of studies have been led to evaluate the impression of community inhabitants following the ongoing COVID-19 flare-up. Because we are focusing on the patient, we are focusing on the healthcare provider, but what the community inhabitants are doing, that we have lagged. So along these lines, in this study, we researched basic knowledge, risk perception, and preventive actions, which was done by residents during the 2020 outbreak of COVID-19 in India. So the statement of the problem is knowledge, risk perception, and precautionary actions which were taken by residents regarding COVID-19, an online cross-sectional survey. Objectives of the study are to assess the basic knowledge of residents regarding COVID-19, to assess the risk perception of residents regarding COVID-19 and compare them with other selected diseases, accidents, etc. Then to determine the various precautionary actions which were taken by the residents regarding COVID-19 pandemic. Methodology, an online cross-sectional survey design was employed for the study, keeping in mind precautions regarding safe distancing. So it was an online study. This was carried out in various states of India by preparing an online survey on Google Sheet. Study population consisted of all Indian residents above 18 years of age, and study sample comprised all Indian residents above 18 years having email account, WhatsApp account, had smartphone and access to internet. Sample size of around 350 to 400 residents were predicted to enroll in the study using snowball sampling technique. This Google form which was prepared was sent to around 1,000 residents, and only 333 people responded back. After checking for completion of their information, 228 forms were finalized for the study. The study was done in the year 2020 and data was collected from 26th April to 29th June 2020 using an online Google form which was prepared by the researcher after thorough search and expert opinion. Ethical permission was taken from the Ethical Committee of the City University and also Departmental Research Committee. Inclusion and exclusion criteria, Indian residents of at least 18 years of age were included, adult residents who are willing to participate in study, adult residents who have internet connectivity, email account, WhatsApp account, and smartphone, and who are able to understand the content of the questionnaire. And the exclusion criteria were who were not willing to participate in the study, they were not having any internet connectivity, smartphone, email account, or WhatsApp account, and who were not able to understand the content of the questionnaire because no one was available to make them understand. It was a Google form, so it was a criteria. Tools used for data collection. For the knowledge questionnaire was used to assess the basic knowledge of residents regarding COVID-19. Then to assess the risk perception, a Likert scale was used regarding COVID-19, and also it was having COVID-19 risk perception along with other selected diseases and accidents. Then self-reported questionnaire was used to assess the precautionary actions which were taken by residents regarding COVID-19 pandemic. All the tools, they were prepared using the Google form and they were sent to the participants using WhatsApp account or email account. So the major findings, like socio-demographic variables, if we see, the gender-wise percentage distribution in the population was The pie chart shows the distribution of participants gender-wise. 55%, that is 180 participants, they were females, and 45%, that is 148, were the male participants. And in the next figure, the percentage distribution according to educational status, it shows that educational status of the participant in that 36.3%, that is 119 residents, they were graduate, 30.5%, that is 100 were postgraduate, 26.2%, that is 86 of them, they were 10+2, and 3.4%, that is 11 participants, they were having PhD degree, and 3.7%, that is 12, they were having other qualifications. Then percentage distribution according to occupational status, what they were doing in their occupation. So it shows that majority of, that is 52.4%, 172 residents, they were students, 17.1%, that is 56, they were working in private sector, 15.9, that is 52, they were working in health and allied health sciences sector, 4.3%, that is 14, they were having other occupations, and 3.4%, that is 11 residents, they were self-employed, and 3%, that is 10, were working in government job, and 2.1%, that is 7 residents, they were unemployed, and 1.8%, a very small percentage of participants, they were homemakers. And if we see the zone-wise percentage distribution of respondents, majority, that is 73.8%, that is 242 out of 328 participants were from the north zone, 18.3%, that is 60, were belong from west zone, and 6.1%, that is 20 residents were from south zone, 1.2%, that is 4 residents from east zone, and only 0.6, that is only 2 residents belong from central zone of India. Then regarding their level of knowledge, the bar diagram above shows the knowledge level of participants regarding COVID-19. So we can see here 60.4%, that is 198, had moderate knowledge, and 36.6% were having adequate knowledge, and only 3% were having inadequate knowledge. Because the pandemic was going on, so much information was going on, so most of the people, they were having moderate to adequate knowledge, and only 3% were there who were having inadequate knowledge. And as I said, the second objective, risk perception of COVID-19 and other disease condition. So it was compared with, COVID was compared with acquiring flu or common cold, having a heart attack, having cancer, home accidents, road traffic accidents, and acquiring HIV or AIDS. So it was seen that 15.5% of residents, they thought, they perceived that they don't have any risk of acquiring COVID-19, whereas 32% perceived that risk of acquiring COVID is highest on a scale of 0 to 7. So they ticked on 7. So they perceive that it is highly risky. Then if compared to flu or common cold, 5.8% was having risk perception that they will not get flu or common cold, and 29.60 had perception that they have the highest risk of getting the flu or common cold. And if we talk of risk perception of heart attack, 8.8% had very, they had perception of no risk of having heart attack, and 55.5 residents had the perception that they has the highest chance of getting the heart attack. And like similarly, the major diseases like cancer also, 9.5%, they had the perception that they have no risk of getting this cancer, and 61.6% has the perception of acquiring cancer as the highest. Home accident, if we say 4.3% had the perception that there will be no risk of having the home accidents, and 50.3% has perception that they have the highest risk of getting home accidents. Then regarding RTAs or road traffic accidents, 6.4% perceived low risk of having road traffic accidents, and 50.3, same percentage again, they had the highest risk perception of getting road traffic accidents. And HIV/AIDS, the maximum number of people, they have the perception of getting HIV/AIDS. That is 68.6% residents, they had the perception that they will get AIDS. So this is the risk perception of COVID-19 as compared to other disease conditions. So we can see that people, maybe they were not having that much knowledge, or maybe they were taking proper precautions. So they thought that there is 15.5%, that is the highest percentage in no risk. They had the perception that they will not get COVID-19. Then regarding their precautionary actions, these were the questions like avoiding to visit a doctor because they were thinking that they will get the COVID, avoiding those people who are not wearing masks. So we can see the percentage who were saying yes to all these precautions. So 72.3% people or residents, they were avoiding to visit a doctor because they were worried that they will get the COVID. So 59.50% of residents, they avoided those people who were not wearing masks. 94.50, they avoided traveling to COVID-19 infected areas. 94.80%.
1 minute left.
Pardon?
1 more minute left.
Okay. So they were giving more attention to cleanliness and taking vitamin C supplement. 59.50%, they were taking vitamin C supplements. Eating a well-balanced diet was 87.90%. Avoiding traveling by public transport, they were 97.30, were not traveling by public transport because they will get the COVID. Not going to school or workplace because of lockdown also, and they were worried also. Avoiding online food ordering, 93.30% were not ordering the food online. Using mask while going out, 93 were using these precautions. Using disinfectant to disinfect the various surfaces, it was 87.20%. Avoiding eating in food centers was avoided by 97.60%. Avoiding social gathering, again 97.30%. Avoiding handshakes, and we are lucky to have in India, and we have Namaste. So avoiding handshakes for 96% of residents. Washing hands more often, it was 95.10% of residents. So the implications are like much more efforts are needed to understand the factors that promote precautionary behavior in times of pandemics. The ever-changing nature of infectious disease transmission suggests that behavior by several individuals may have a significant impact on the trajectory of an outbreak. However, individuals may not take precautions if they are not aware or they have wrong or inadequate knowledge about the outbreak. Therefore, more accurate COVID-19 knowledge leads to greater precautionary behavior, and coupled with the fact that there are already myths and conspiracy theories surrounding the origin and nature of COVID-19, it is recommended to conduct enlightenment campaigns aimed at promoting adequate and accurate knowledge of the COVID-19 pandemic and removing misconceptions and misinformation about the disease. In places where such knowledge is already influenced by conspiracy theories, it is important to reorient the public on real nature and origin of the disease. In unaffected areas also, true risk may be low, but due to worldwide media coverage of pandemic or infodemic, there is a possibility of elevated level of risk perception. Therefore, the scientific community may leverage on this and explore ways to best communicate risk to individuals without unnecessarily causing the panic. Individuals who perceive themselves as being at risk of contracting the virus should engage in precautionary behavior as suggested in this study rather than from stereotypes and prejudices against persons perceived to be the sources of the disease outbreak. Therefore, it is necessary that knowledge, realistic risk, and effective precautionary behaviors are communicated through various information sources so that people can engage in more preventive behaviors than merely depending upon the vaccines. So this study can serve as a proactive step towards curbing future endemics and pandemics. Thank you very much.
Thank you so much.
Thank you, ma'am.
Are there any questions? Questions?
Okay.
All right, let's proceed. Let's recall oral presentation by Gitanjali Sirwal from
Yes, ma'am.
SG. Hi, from SGT University, India. Your
Yes.
topic is about a descriptive study to assess the knowledge regarding cervical cancer and its prevention among female students of first year of SGT University, Gurugram. Perfect. Go ahead, please.
Thank you, ma'am, for this wonderful platform to present our topic. Okay. So good afternoon, everyone. Myself, Gitanjali, and I am tutor from Faculty of Nursing, SDT University. And my topic is a descriptive study to assess the knowledge regarding cervical cancer and its prevention among female students of first year students of SDT University, Gurugram. And my objectives were to assess the knowledge regarding cervical cancer and its prevention among female students of first year of SDT University, and to find out the association between knowledge score regarding cervical cancer and its prevention with selected demographic variables of SDT University, Gurugram. So cervical cancer is a type of cancer that occurs in the cells of the cervix, the lower part of the uterus that connects to the vagina. And because of its abnormal growth of cells that have the ability to invade or spread to other parts of body. So early on, typically there will be no symptoms will be seen. So later symptoms can be including abnormal vaginal bleeding, pelvic pain, or pain during sexual intercourse. So cervical cancer can be one of the most common cancers worldwide. So in recently studies that they have reported from India that on awareness of cervical cancer and its screening among women, studies exploring the knowledge of the women about cervical cancer have focused on either on nursing staff working in hospitals or on women in the rural community. So hence, in this study, researcher wants to conduct the study because of the increasing rate of cervical cancer in the early ages due to the low knowledge, more prevalent in low groups. By assessing the level of knowledge of the first year students, we can able to prevent and treat the condition at an earliest so that they can be more aware about the cervical cancer at early age itself. So there are some glimpses of previous studies that have been done. So one study was done by Kusum Lata and Akoyjum Mamta Devi in 2019. And they have conducted a pre-experimental study to assess the effectiveness of plant teaching program on knowledge regarding early detection and prevention of cervical cancer among 60 women of selected village in Gurugram. And the study results revealed that the pretest knowledge score was 35% that had poor knowledge, 60% had average knowledge score, and 5% had good knowledge score. And post-test knowledge has shown that none of them had poor knowledge score. 25% were having had average score, and 75% had good knowledge score after the study. Then in second review done by Tanya Shubham and Kumar Harsha Ejan in 2019, they have conducted a cross-sectional study on knowledge and screening for cervical cancer among women in Bangalore city. And in this study, majority of women have poor knowledge about cervical cancer, that is around 81.9%, and its screening, it's about 85.5%. So only 6 out of 83 women had undergone screening. So as you can see that the knowledge score were also less in the women or in the students, and also the screening and the prevalence rate was also low. Like knowledge were also low, and the number of women, that is 6 out of 83. So it is a least score that we can see. So in my research methodology is research design. A descriptive study design was adopted for the study. Research setting. The study was carried out in the SJT University itself in Gurugram, Haryana. Samples were all first-year female students of Faculty of Allied Health Sciences, Physiotherapy, Nursing, and Indian Medical System of SDT University, Gurugram. Sampling technique was total enumerative sampling technique. Sample size were 160 female students were selected for the study. Then the inclusion criteria for the study, the participants who were fulfilling the following criteria included in the study. All first-year female students of Faculty of Allied Health Science, Physiotherapy, Nursing, and Indian Medical System were only the part of the study. All the participants who all were willing to participate in the study were following the inclusion criteria. Then the exclusion criteria was only participants who were not willing to participate in the study from these various faculties. Then tool for data collection. It was consisted of two tools. The tools consisted of two sections, that is tool 1 demographic variables and tool 2 was structured knowledge questionnaire. So in tool 1 demographic variables, it was consisted with like age, sex, marital status, educational qualification of the students, and the source from which they are getting the information about related to health and disease conditions. And in the tool 2, it was consisted with structured knowledge questionnaire, which is used to assess the knowledge regarding cervical cancer and its prevention among female students of first year of SFNP University. And it consisted of 20 questions, which was related to cervical cancer and its prevention. Then the ethical consideration, which is also an important step in doing the research. So administration permission was taken from the Dean Faculty of Nursing, SDT University, and ethical permission was also taken from the ethical committee from SDT University. And written consent was also obtained from each study participants, and assurance was also given to each subject regarding the confidentiality. Next, analysis. So distribution of subjects according to various socio-demographic variables. So if we talk about age, so 36.50% of students were falling in 17 to 18 years. Then 46.80% of students were falling in the criteria of 19 to 20 years. Then 3.20% of students were in 21 to 22 years. And 13.50% of students were 22 and above years. If we talk about religion, so there were none of the students were Sikh, and most of the students were Hindu, that is around 94.30%. Muslim, it's about 3.80%, and others will be 1.90%. Then if we talk about marital status, so none of the students were widow and divorced, and around 95.50% of students were unmarried, and only 4.50% of students were married. Then in educational status, so students who are who have done their education qualification up till graduation was private only, that is 97.50%, and only 1.90% of the students has attained the qualification from the government institutes, and 0.60% of students have done their educational qualification from OT, and none of them have attended any military institution for education qualification. Then last variable, from which source that they are acquiring health related information. So around 25% of students were attaining their health related information from mass media and the news channels, and around 23.10% of students were attaining their health related information from their peer groups and family members. Then 44.20% of students were attaining their health related information from health professionals, and there will be other sources like others from where they are getting health related information, that is about 7.70%. Then if we move on towards next section, so frequency and percentage distribution of knowledge of
1 minute left.
of first year regarding cervical cancer and its prevention. So 4% of students were having poor knowledge, 61% of students were having average knowledge score, and 35% of students were having good knowledge score. Then if we talk about knowledge part, that the maximum score was 20 only, and the mean was 13.301, median was 14, and standard deviation was 2.79. Move on to next section regarding the association between knowledge scores with their socio-demographic variables. So there was significant association between knowledge with educational status and religion, that is around 0.276 and 0.354. That was significant. And there was no significant association with the knowledge with age-related status and source from which they are acquiring the health-related information. That is around 0.069, 0.197, and 0.192. So in this association, we have found out that the religion and the educational status are having great impact if the student wants to increase their knowledge regarding the cervical cancer, and they were having. So conclusion for my study, that this study concluded that there was a significant association in knowledge score and selected demographic variable like educational status and religion, and also the female students were having average knowledge score. So it shows that the adolescent girls should be educated more regarding the cervical cancer and its prevention, and it should also be included in the education curriculum also in different areas, not in the medical only, in different areas, in different faculties also, so that they can attain knowledge related to cervical cancers, as most of the adolescent girls are not aware about the prevention part, or what are the different diagnostic criteria are there, so that they can able to assess or identify whether they are coming in their region or not. These were my references for this study. So thank you. That was my presentation, and thank you for giving me this platform.
Thank you so much. Are there any questions?
Yes, my question is that, hello?
Yes,
go ahead.
Ma'am, for the research study, she has not done any intervention. So only by assessing knowledge, how you can prevent the cervical cancer?
Only by assessing the knowledge. Actually, ma'am, we have assessed the knowledge of different female students, and then afterwards we have not done any intervention that I know. But after assessing their knowledge only, they were having many questions related to this. So we were planning to do more research related to this, more interventional studies. So first of all, we were assessing the knowledge level from different adolescent girls of different faculties. So now we are planning.
You can do some interventions. Now that only it is useful. If you are doing this research, there should be at least a knowledge questionnaire, at least one knowledge audio or video knowledge you should give now. Otherwise, what is the need in doing such a thing only to assess the knowledge?
Yes, ma'am.
Okay, check.
Thank you so much. You may stop sharing. Now, the next oral presentation by Amandeep Kaur, Chitkara School of Health Sciences, Chitkara University, India. The topic is about a descriptive study to assess the prevalence of physical and psychological problems due to virtual teaching learning activities during COVID-19 pandemic among the students. Amandeep?
Good afternoon, ma'am.
Hi.
Ma'am, wait a minute.
Go ahead and share your screen, please.
Ma'am, I'm not able to share.
Gisela? Amandip?
Yes, ma'am. Yes, ma'am.
Can you please?
Share the screen, Jojo.
Can you go ahead and try it again? Share again? Amandeep?
Ma'am, option is not shown here.
Amanda, please complete your Zoom application.
All right, I'll call you after the next presenter, all right?
Okay, ma'am.
All right, let's proceed with the next oral presentation by Seema Rani from Rufida College of Nursing, Jamia Hamdard University, India. The topic is about a pre-experimental study to assess the effectiveness of video-assisted teaching that on knowledge and attitude regarding attention deficit hyperactivity disorder or ADHD among primary school teachers in selected schools of Gurugram, Haryana. Seema?
Yeah. Actually, you have read it by mistake.
I'm sorry?
Hi, good afternoon, everyone.
Topic. I am well aware that we are all from different time zones of the globe. So I thank you for providing this platform to me. But I am not able to share the screen.
Can you help share screen?
Yeah, just I will try again because it is not getting shared. Yes, just a minute. I'll just try again. Share and
yep, there you go. Perfect.
Yeah.
Yep. Oh, it's gone.
I think there is some technical glitch. I'll be back in 5 seconds only. Just in 5. Give me 5 seconds, please. So, is my slide visible to you all?
Not yet. Coming up.
Not yet. Oh. I'm so sorry to keep everybody waiting.
All right, we'll get back to you. All right?
Yeah, sure. Thank
yes,
you.
So we can
Thank
have
you.
time to share.
Yeah.
All right, next let's have an oral presentation by Nikki Tyagi from SGT, India. The topic is about a pre-experimental study to assess the effectiveness of video-assisted teaching. Oh, I see. It's yours. Teaching that knowledge and attitude regarding attention deficit hyperactivity disorder, or ADHD, among primary school teachers in schools of Gurugram, Haryana.
Yes,
Nikki?
yes, ma'am. Hello, good afternoon, everyone. My name is Nikki, a tutor PG from SDT University, Gurugram, Haryana. And first of all, I would like to thanks for providing me the opportunity to present my paper. So the statement of my problem is a pre-experimental study to assess the effectiveness of video-assisted teaching on knowledge and attitude regarding attention deficit hyperactivity disorder among primary school teachers in selected schools of Gurugram, Haryana. So my guide is Professor Ramandeep, HOD of Mental Health Nursing Department, SDT University, and my co-guide is Ms. Poonam Ehlawat, Assistant Professor, SDT University. So introduction. Mental health problem affects a large number of children and adolescents and continue to be on the rise worldwide. The global burden of disease suggests that by the year 2020, childhood neuropsychiatric disorder will increase by more than 50% internationally to become one of the 5 most common causes of childhood illness and disability. Attention deficit hyperactivity disorder is the most prevalent neurodevelopmental disorder in children and is becoming a major public health problem. So the need of the study. Children spend most of the time in classrooms and are in various school settings. In the school, they are expected to abide by rules, behave in socially acceptable ways, take part in academic activities. ADHD is defined as a persistent pattern of inattention and or hyperactivity, impulsivity that interferes with functioning or development and is characterized by 6 or more symptoms from each or both the inattention group of criteria and the hyperactivity impulsivity criteria. ADHD have an impact on students' educational and social performance due to difficulties in sustaining attention, failure to finish tasks, forgetfulness, and excessive non-goal-directed physical activities. Primary school teachers are the primary person to see children in formal group settings and can identify developmentally inappropriate behaviors because they have direct experience of the students in classroom situations. In India, as we all know, it is very difficult for the health professionals, health personnel to screen millions of students and identify children with ADHD. So the primary school teachers are the best suited for this purpose and can guide both children and parents. Therefore, it is very important to sensitize the teachers about ADHD and make them aware and utilize their crucial role in early identification of problems and early referral, because early identification and intervention have shown better prognosis in a number of childhood psychiatric disorders. So the objectives of the study, my first objective was to assess the pre-test knowledge regarding ADHD among primary school teachers in selected schools of Gurugram, Haryana. The second objective was to assess the pre-test attitude regarding ADHD among primary school teachers in selected schools of Gurugram, Haryana. The third objective was to assess the effectiveness of video-assisted teaching regarding ADHD among primary school teachers. And fourth objective was to find out the association between post-test knowledge scores among primary school teachers with selected demographic variables. And the fifth objective was to find out the association between post-test attitude among primary school teachers with selected demographic variables. So the glimpse of the previous studies. So the researcher Prerna Karki, Lirani Tongo, and Arkidu Pai Shadap conducted a study in the year 2019, and a pre-experimental study was done to assess effectiveness of instructional module on knowledge regarding ADHD among primary school teachers in selected schools of Gangtok, Sikkim. So the results were a total of 80 primary school teachers were selected using the purposive sampling technique, and the findings revealed that the majority, 60% of the primary school teachers have average knowledge in the pre-test, whereas in the post-test, 86.25% had good knowledge. So the study concluded that educational material in the form of self-instruction module helped the teachers to improve their knowledge on ADHD. So the second study done by Vijayata Basin, Jyoti Sareen, and Srinivasan P. Did a quasi-experimental study to assess the effectiveness of video-based teaching on knowledge and attitude regarding ADHD among primary school teachers. So the study revealed that the mean post-test knowledge score and the mean post-test attitude score was higher than mean pre-test knowledge and attitude score in the experimental group. So it was concluded from their research that the video-based teaching was effective to improve the knowledge and attitude of regarding ADHD of the children. So the research methodology. So the research approach was quantitative research approach. Research design was pre-experimental, one group pre-test post-test. Research setting was selected schools of Gurugram, Haryana. The sample was primary school teachers, and the sample size and sampling technique was the sample size of mine was 60 primary school teachers, and the technique used was total enumeration sampling technique. The tools of data collection, knowledge questionnaire and attitude rating scale was used to collect data, analysis and interpretation of data. Descriptive statistics and inferential statistics was used. In descriptive statistics, mean and standard deviation was calculated, and in inferential statistics, chi-square and pair t-test was employed. Eligibility criteria: teachers that were present at the moment of collecting data. Second, teachers that were ready to participate. And the third, teachers that were taking class from 1st to 5th standard. So the description of the tool consisted of 3 sections. Section A, socio-demographic variables. It consisted of age, gender, marital status, qualification, teaching grade, teaching experience, previous knowledge regarding ADHD, and if yes, specify the source of information. Section B, this section consists of self-structured knowledge questionnaire, which includes 30 multiple choice questions to assess the knowledge regarding ADHD among primary school teachers, and each correct answer carries 1 mark and wrong answer carries 0 marks. Section C, this section consists of self-structured 5-point rating scale to assess the attitude of primary school teachers regarding ADHD. It consists of 20 statements, and the minimum score was 20 and the maximum score was 100. Content validity. The tool was submitted to 1 psychologist, 1 psychiatrist, 2 educationists, and 3 experts from the mental health nursing for validation. Experts were requested for their recommendation, and further changes were done accordingly. Ethical considerations. Ethical permission was taken by the Ethical Committee, Faculty of Nursing, SDT University, Gurugram, Haryana. Before conducting study, written consent were taken from all the participants. Data analysis. The findings of the study were grouped and analyzed under the following sections. Section A, description of demographic variables of primary school teachers. Section B, assessment of pre-test and post-test level of knowledge and attitude regarding ADHD among primary school teachers. Section C, effectiveness of video-assisted teaching on knowledge and attitude regarding ADHD among primary school teachers. Section D, association of post-test level of knowledge with selected demographic variables. And Section E, association of post-test attitude with selected demographic variables. So Section E consists of demographic variables of primary school teachers, as this is the figure which shows the percentage distribution of age of primary school teachers, in which the majority of the teachers were belonging in the category of 31 to 35 years, and 15% of teachers belongs to 21 to 25 years, and 28.3% of the participants were in the group of 26 to 30 year, and 25% were above 35 year. The next is the bar chart showing the percentage distribution of gender of primary school teachers. So the majority of the participants were in the category of female, and 3.3% were in the category of male. So the next bar chart, which shows the percentage distribution of marital status of primary school teachers. So the majority of the participants, that is 70%, were in the category of married, and 25% were in the category of unmarried, and 5% was in the category of others. Regarding qualification, so the majority of the teachers were masters and above, and 38.3% of the teachers were in the category of bachelors. So this is the bar chart which shows the percentage distribution of the teaching grade. So the majority of the participants were in the category of second grade, were teaching to the students of second grade, that is 23.3%, and in first grade 16.7% of the teachers were categorized, and in the category of third grade 20% of the teachers were categorized, and in the fourth grade 21.7% of teachers, and 18.3% of the teachers were in the category of fifth grade. And so now the teaching experience, the majority of the teachers were in the category of 3 to 8 years, and 25% of the teachers were having less than 3 years of experience, and 25% of teachers were having the experience of 9 to 14 years, and only 1.7% of the teachers were having 15 and above teaching experience. Previous knowledge, the majority of the participants were not having previous knowledge regarding ADHD, and only 23.3% of the participants were having previous knowledge regarding ADHD. So the source of information was specified. So 6.7% of the participants were in the had the knowledge regarding ADHD through media, and 16.7% of the participants had knowledge through internet. So this is the pre-test and post-test level of knowledge and attitude regarding ADHD among primary school teachers, as depicted in the bar chart. It shows that 68.3 in the pre-test, 68.3% of the participants were in the inadequate knowledge category, and 31.7% were in the moderate knowledge category. Whereas in the post-test, 25% were in the category of moderate knowledge, and 75% of the participants were in the adequate knowledge. So this bar chart shows the percentage distribution of pre-test and post-test attitude. So in the pre-test, 46.67 were in the category of unfavorable attitude, and 53.30% of the participants were in the category of neutral. Whereas in the post-test, 21.67% of the participants were in the neutral category, and 78.3% were in the category favorable category. So the effectiveness of video assisted teaching on knowledge and attitude regarding ADHD among primary school teachers. So this table depicts the comparison of pre-test and post-test knowledge score, whereas we can see that in the pre-test the mean score was 9.85, and in the post-test the mean score was 22.40 with a mean difference of 12.55. The pair T value was 25.936, and p value was 0.00, which was found significant at 0.05 level. Now this table depicts the comparison of pre-test and post-test attitude. In the pre-test, the mean score was 48.97, and post-test the mean score was 79.48 with a mean difference of 30.51, and the pair T value and the T value was 23.299, and the p value was 0.00, which was found significant at 0.05 level, which shows that the video assisted teaching was significant, was very enhancing. So section D, it shows the association of post-test knowledge score with selected demographic variables. The demographic variables such as age, gender, marital status, qualification, teaching grade, and previous knowledge had not shown any statistical significant association, but the teaching experience had shown statistical significance at 0.05 level with selected demographic variables. So section E, association of post-test attitude with selected demographic variables. The demographic variables had not shown any significant statistic association between post-test attitude with selected demographic variables. So the conclusion was, the study concluded that the educational material in the form of video assisted teaching helped the teachers to improve their knowledge and attitude regarding ADHD. The gain in the knowledge from video assisted teaching will help the teachers to identify and manage children with attention deficit hyperactivity disorder in the classroom and in the other settings. The recommendation, a research can be conducted to determine efficacy of video-based teaching with another educational method. A comparative research can be done to observe the differences in knowledge among teachers belonging to rural and urban areas, and a true experimental study can also be done on this topic. So the references were the following. Thank you.
Thank you so much. And do we have questions?
Hello.
Hello. Can you hear me?
Yes, ma'am.
Are there any questions? All right, then let me call back Amandeep Kaur.
Yes, ma'am.
Hi, yes. Go ahead and share your screen, please.
Okay, ma'am.
Were you able to share your screen?
Is it visible?
Not yet. Let's wait.
Ma'am, is it visible?
Not yet. We're waiting. Were you able to click on the share button? After clicking on share screen, you will be able to see another screen. You need to click on your entire screen, then click on the another share button. Were you able to see that?
Ma'am, still I am not able to share.
Gisela, can you please assist her? All right, I'll just call you back later. Next, let's recall an oral presentation by Seema Rani.
Thank you so much.
From Rufaida College of Nursing, Jamia Hardad University, India. Go ahead.
Yes, I will. Yeah, so I hope my screen is visible. Hello.
Nope. And
no.
You need to click on the entire screen, because if you're going to choose only one screen, it will not show up.
Yeah, now is it visible?
No.
Oh, why it is playing up?
On your end, yeah. When you share screen, you need to click on the.
Yeah.
All right, Seema, let me go ahead and share my screen. Hold on. Oh, you will not be able to see the screen either. On your Zoom application, when you click on share screen, what do you see? Seema?
Seema ma'am?
Yeah, Seema?
I think she is not audible.
Seema? And she's gone.
Yeah,
All right, let's go. Let's go ahead and proceed with our next presenter then. Amandeep, are you okay there? Next, let's go on our presentation by Prempati Mayanglamban from Galgotias University, India. The topic is about the assessment of knowledge and attitude regarding temporary spacing methods among reproductive age women in urban slums of Nakachandravadani, Gwalior, MP. Hi, Prempati. Prempati? And I think she's gone too. Seema? Well, that's about it. We are actually almost done. We're just having some technical issues with the last participant. We can still give them time because we're still going to wait the other session to finish. Yay, I can see now Amandeep's screen. Amandeep, are you there? Can you mute yourself?
Yes, ma'am.
Perfect. Go ahead and share your screen.
Ma'am, my PPT is visible to you.
Earlier, yeah, now it's gone.
Ma'am, give 1 minute, please.
Ma'am, it is visible.
Yes, it is, and I can hear you. Please, please proceed. Yeah, go ahead. Let's welcome Seema Rani on Student Community Pan India during COVID-19. You're on mute, Seema. Seema, you're on mute.
Am I?
Yes, you are.
Good now? Yeah, okay.
Yep, go ahead.
Yes. So, sorry. So I have to say sorry again. I'm really, really sorry that because of this technical glitch and my incompetency, and that is exactly what my presentation is all about today. So it is to assess the impact and perception of online classes on a student community pan-India during COVID-19. And we all know that earlier physical classes were the only options that we had for teaching learning activity, but due to the change in the technology and due to the pandemic COVID-19, this has absolutely taken it 180-degree turn, and it has, for so many reasons, after WHO declared pandemic for COVID-19 in March 2020. So education system also became very fragile, and of course the schools were closed, everybody was affected, and studies show that 90% of our students got affected. So there are many studies, although online teaching learning is not very new thing for us. All over the world since 1990s, we have been used to this technology, because through WhatsApp, through emails, through sharing of notes, Googling, and so on. But because of this, when complete transformation of offline classes into online had to take place since around April 2020. So after that, it was the concern. And then in this backdrop, I thought of taking impact and perception of students, and if there are any issues that they had faced during this. So objectives of this study were to assess the perception of students and to assess the impact on them during this outbreak, and also the issues and challenges that they faced while taking up these classes. So methodology adopted for the study was a quantitative approach. It was a descriptive survey design, and the population was all student and university students, and sample size was 100 students from 8 states and 2 union territories of India. It was simple random sampling, and the tool that I used after getting validated, after checking the reliability, it was a structured questionnaire which had 3 sections. First was about demographic variables, second was about perception, and third was to assess the impact. And then later on, some subjective questions were there to find out the issues and challenges that they face. So it took around 20 minutes for each subject to complete the questionnaire. And the statistics employed was descriptive statistics. Written consent was taken for ethical consideration from each participant before taking up the study. Delimitation of the study was that it only could enroll the students who had their smartphones, internet connection, and they could comprehend English. So about the results, so about socio-demographic variables, the course of study, like around 50% were middle school students, and 25% were secondary students. Secondary students, when they say for global community, I would like to explain that when we say secondary, it means around 15 years, like 13 to 15 years of age, and senior secondary is like 16 to 19 years, and then graduation and post-graduation is when they go to the college or university. So 60% had uninterrupted power supply at their place, and 65% used it Wi-Fi through modem. And then, well, this is alarming because most of the students spend 2 to 7 hours for online classes, and it is only and only for school classes. It does not include any other extra classes, tuition classes, and so on. And monthly expenses was again an issue, and 50% said that they had to incur additional 500 to 1,000 rupees a month. And 44% said they had a separate room, but others did not have, and so that was an issue. And this is like other tuition classes. 46% spent more than 2 hours on the screen. So regarding perception, when they were asked that out of 157, 55% said that theoretical experience can be given. 55% of them said yes. When it came to practical, 80%, 79% said that practical experience cannot be given through online classes. Were the classes well organized? 56% said yes, it was organized structure. 62% thought that online grading system, that is, they could not be evaluated properly through this mode. Only 52% said that study material was provided to them before classes, and 45% said after classes it was provided. So when asked that what is their preferred mode of learning, so 25% said online mode, face-to-face, that is class, that is around 50%, and rest of the students were of the opinion that mixed mode could be a favored option. So in terms of convenience, as advocated all over the world, but against that norm, only 40% said that it was a convenient way of learning. Okay. Then students also commented on their teachers' capability to take online classes. 45% only said appropriately the teachers were equipped with technology, experience, knowledge, but otherwise they were not happy with the teachers' update about this, using this technology. And then 20% said that teachers were not willing to clear their doubts during or after classes, although majority said it was cleared. Then when it came to interaction of the during the classes or after the classes, they said 68%, majority said that it did not allow interaction. Impacts, I saw impacts in terms of health, finances. So impact was 42% said that sleep disturbance was there for because of this online classes. Eye problems, majority like 68% said. Socialization problem, that is, they had to stay home, they could not interact with the peer group, with the friends. So 59% said like they had problem in socialization, and posture related problem, 62.4% said posture related problems were there, and ear problem, 62% said there was no problem. Physical activity was altered, problems was there. Yes, 72% said yes, it is problem is there. Then 74% said that they had eating habits related problem, and 65% said that they started some alternative physical activity because schools were closed. Then sleep disturbance was experienced, perceived by around 43% of the students, and eye problems due to online classes 68%, and so on. Okay. Well, average screen time, 60% said 5 to 8 hours per day they had screen time, which is significant, which is really significant. 25% students said, only 4% students said that they had same or reduction in weight, whereas 76% reported weight gain as compared to the pre-online class commencement. And this gain was marked like as 10% to 25% of the pre-online classes weight. Among the posture problems, they reported pain back, low back pain, forward bending of shoulders, and stiff shoulders. These are the impacts about the eye problems. So 49% said pain in the eyes, 55% said watering from the eyes. So these were two significant. Then headache due to online classes, 66.4% said, and we specifically asked the question that it was only during this time and not before that. So 66% said they had headache. Well, these are the ear-related problems. They said pain in the ears, 47%, 64% said, again, reported headache, giddiness. Chakkar is giddiness or vertigo, 20% reported this. And altered physical activity and no time for relaxation or play, it was around 69% of them felt that there was no time for play or relaxation, no time for exercise. Then for extracurricular activities, also for hobbies, they found very little time. And the alternative physical activities which were taken up by them was walking, climbing the stairs because of the curfew, lockdowns at various places, doing squats, push-ups, gymming at home, yoga, and skipping. So eating habits, I started eating junk food, irregular time eating, eating junk food by 31%, overeating by 26%, and undereating by 20%. On the contrary, 24% reported that they had started eating more healthy food during this period. Okay, and these are the few issues and challenges when they were asked subjectively that they can express freely. So these are just a few that we have penned down. It was, many of them said it is a waste of time, efforts, and money, although they said that it gives better time, ample time for self-study. So it was a mixed opinion. They had issues, eye problems, headache, sleep disturbance, and distraction at home because they did not have adequate separate place to study, to take online classes. They had to share their space. So it was not giving, they were not able to concentrate properly. So, and then teachers' lack of technical knowledge, financial constraint, lack of socialization with the peer group were other issues. These all the study findings are, some are in line with other studies and some are in contrary. So contrary to the current study results, perception of the university students towards e-learning during pandemic shows that it provides more freedom to connect with the teachers and engage with their study material at comfort and flexible time and space. And whereas the current present study findings are in line with another study by Mukhopadhyay et al., wherein students believe that online classes are not sufficient for them, mobile data is not enough to work, it requires strong bandwidth, and teachers and students felt physically apart and missed the lively environment of the classroom. So again, these are in line with other study findings also. Then this study, there was another study for agricultural university students, perception towards online classes during this time, and then they found that flexibility and convenience make it an attractive option, whereas 60% said that it is less effective if compared to the face-to-face classes. They also said that digital divide is there, so it is not equally distributed. So, and there are other studies likewise. So these are the implications, because this study was not taken precisely for nursing students. This was for all the students of schools and universities. But then if we talk of implications in nursing field, nurse educators also have to take lessons from students' feedback of online classes. Hybrid mode of teaching, it seems to be a new normal for all educational institutes from now onwards. So nursing schools and nurse administrators have to be prepared for the change. They have to update their teachers and technology. More in-depth research studies need to be taken in this area. Then in clinical practice, students in many studies and also in the current studies express that it is a limitation, major limitation, because practical aspects cannot be taught effectively by online classes. So this has to be looked into. So I give conclusion of the study that online classes are not a substitute of the offline classes. However, during pandemic, it was a rescue operation to impart learning. Students and teachers need to be technically prepared to take on this method. And online method has many health impacts which need to be addressed. So thank you all, my dear friends, all across the globe. I really thank you. And once again, I apologize for the technical glitch that we all faced in the beginning.
Thank you so much. Thank you so much. Are there any questions? I think none. All right,
Okay.
good job. And
Thank you. So thank you once again. And I'm really, really sorry to waste so much of time of all the people listening to this. Okay, thank you.
No problem. All right, and thank you all participants for your presentation. And now I think we've closed the other room. And now let's I would like to invite Professor Dr. Sudarani Banapudugudar, Professor, School of Nursing, ITM University, India, to deliver the vote of thanks. Hi, madam.
Thank you. Namaste and Jai Bharat to all. I, Dr. Sudarani, Professor, School of Nursing of our entire School of Nursing Sciences and ITM University family. I feel honored and privileged to get the opportunity to propose the vote of thanks on this special day. This is the proudest day for our School of Nursing Sciences, ITM University. We have hosted this conference with more than 200 participants from the various educational institutions from India and abroad. On behalf of School of Nursing Sciences, ITM University, I convey my regards and hearty thanks to our co-founder, Sir Shri Ramashankarji Sir, Chancellor Ma'am Mrs. Ruchi Singh Chavan, Ma'am, and Pro-Chancellor Sir Dr. Thavlat Singh Chavan Sir, for their guidance and support for the successful event. Thank you, sir. Thank you, ma'am. I must mention our deep sense of appreciation for Dr. Sher Singh Bhankar, Vice Chancellor, ITM University, Dr. Santosh Narayan Khedkar Sir, Pro-Vice Chancellor, ITM University, and Dr. Omveer Singh Sir, Registered ITM University, for their continuous support. Thank you, sir. Thank you all. I take this opportunity to extend our most sincere thanks to Mr. Rudra Sir, CEO, Society for Nursing Practices Association, for reposing faith in us, for hosting the collaborative third international conference. Thank you, sir. My heartfelt thanks to our Honorable Chief Guest, Dr. Rati Bhalachandran ma'am, and Dr. L. Gopichandran for accepting our invitation in the busy schedule. Thank you, ma'am. Thank you, sir. I also wish to express my gratitude to all our eminent speakers from both India and abroad. Thank you, all of you. Thank you so much. I extend my sincere thanks to our academic partners from the various universities across the country. Thank you all for being a part of the international conference. An event of this dimension cannot happen overnight. It requires meticulous planning and it is the involvement of all my nursing faculty and guidance of our team. Thank you all. Thank you, ma'am. My special thanks to all the participants, presenters who were the major part of the conference. Thank you all. I extend my thanks to all the session chairs for evaluating the sessions. Thank you, all the session chairs. I owe special gratitude on the non-teaching staff who worked hard to ensure this occasion to become more memorable success. I also thank to Mr. Robin for providing the delicious breakfast and lunch in this university. So thank you, sir. I thank the members of the media for evincing interest in covering the event and all good hearts who worked behind the screen. Last but not the least, I thank you all for your cooperation in making this function a resounding success. I also thank Sushmita ma'am, Jasila ma'am, Gopinathan sir, and Vignesh sir, a complete team who worked for the successful completion of this third international conference. Finally, I leave this inspiring quote by Martin Luther. An individual has not started living until he rises above the confines of his individualistic concerns to the broader concerns of all humanity. Once again, thank you all. Jai Bharat, Jai Hind.
Thank you so much. Thank you so much, Doctor.
And a special thanks to you, Jojo Mahama, for the finest anchoring.
All right, thank you. My pleasure, my pleasure. And yeah, everyone, yeah, I think we will adjourn the conference. And before that, I will just make a few announcements. So I will be posting a link on the chat box for the certificates proceeding book and the feedback. Please click on this link. And also, I would like to thank all our session chairs and all the participants. Congratulations, good job. And now, the certificates, by the way, that link. So please do. I request everyone to download it. And for the winners, so we will have our judges or session chairs to deliberate. So all the winners will be informed by Monday through email. Again, winners on this conference will be emailed on Monday. And certificates, please, I strongly recommend everyone to download their certificates. And if you are still interested, here's the link for our upcoming conferences. Oh, that's the certificate link. Here's for our upcoming conferences. Thank you so much, everyone. I hope you enjoyed and learned a lot. See you on our next conference. Bye, everyone. Have a great day. Once again, your moderator, Jojo. Bye-bye.
Bye-bye. Thank you all.